sound sleep and good breakfast, and we are ready for the second day. My humble submission is that we have to be a little bit more particular about time management, and we'll start on time, conclude on time, because friends have flight also in the evening or late evening. So Saurabh, I would request you also, when session is going on, that it concludes on time. Please don't mind to give a gentle reminder, otherwise it will have a cascading impact on delay, and we end up concluding the day very late, which is not intended at all. So over to you, Saurabh, and our first speaker is already here, and Saurabh will welcome her. Thank you. Over to you.
Good morning, everyone. Welcome to day 2 of initiative on hemophilia care. This is almost a decade long moment we have started, and earlier it was just awareness, but now we are more into actions. And one of the visionary and I would say very innovative state of India is Punjab, and our next speaker, Dr. Rupinder Kaur from NHM Punjab, is going to present on how the state-led innovation in Punjab is making a difference in the patients' lives, and how it is improvising and making the better care for the patients in Punjab. Over to Dr. Rupinder Kaur, ma'am.
Good morning to all dignitaries. Myself Dr. Rupinder Kaur, Assistant Program Officer from State Blood Services and Disorder Program, NHM Punjab. I am here to describe what are the new initiatives and how we are running the Blood Services Disorder Program in Punjab as the administrative point of view. So, firstly, epidemiologically burden and patient burden. Approximately in Punjab, the population is 3 crore. Or currently on our iCare software, 766 registered patients for hemophilia A and B, and 50 for inhibitors. And we have covered a treatment center to integrated center for hemophilia and hemoglobinopathies in all districts of Punjab. We have 24 ICHH hemophilia thalassemia treatment centers, 4 at comprehensive care tertiary level, 3 medical colleges, and 1 at AIIMS Bathinda. So diagnostic care vision and key pillars. Diagnostic facilities. The basic PT, APTT diagnostic services are available in all district hospitals of Punjab. Under Blood Services and Disorder Program, we have provided 12 semi-automated coagulometers to pathology lab, and in some centers it is established in blood centers for doing PT, APTT, and now we are starting the factor assay also in our district hospital centers. So before that, जो हमारे जो factor assay या PGMR चंडीगढ़ या GG जो गवर्नमेंट मेडिकल कॉलेज फरीदकोट वहीं पे अवेलेबल होता था, तो अभी हम इनिशिएटिव ले रहे हैं कि हम डिस्ट्रिक्ट हॉस्पिटल्स पे भी प्रोवाइड करवा सकें. Then vision of hemophilia care in Punjab: timely, equitable, and comprehensive care for all persons with hemophilia in Punjab, preventing disability, reducing morbidity, and improving quality of life through integrated patient care services. So we are doing for this clinician awareness, universal access to factors, early diagnosis, and multidisciplinary care. Key pillars of vision are clinician awareness, as I discussed earlier, universal access, anti-human factors for providing all district hospitals. They are also added in the essential drug list. Early diagnosis for the patient, we are providing the factor assay and all reagents to district hospitals, and treatment network. Goals. goals are pain and disability free life for hemophilia patients, improve quality of life, normal life expectancy. Pattern of hemophilia treatment, on-demand episodic treatment for factor 8, 9 and APCC fiber and factor 7. These are provided on-demand episodic treatment, and regular replacement therapy are also initiated in the state of Punjab. So vision of hemophilia care in Punjab, aim at ensuring timely, equitable and comprehensive care to all persons with hemophilia in Punjab, preventing disability, reducing morbidity and improving quality of life. Key pillar of vision are to increase awareness and orientation among clinicians. For this we are doing timely orientation, capacity building workshops of the medical and paramedical staffs with the collaboration with our medical colleges and PGMI Chandigarh. Universal and equitable access to anti-hemophilia factors to all districts. Early diagnosis and registration of patients. Multidisciplinary historic care, integrating orthopedic, physiotherapy and dental psychological care. Establish a network of treatment centers for comprehensive care. Enhance the awareness regarding the genetic disorder from grassroots level. Policy and policy support and financial protection. Punjab hemophilia policy. So same the early diagnosis, prophylaxis, expansion, equitable access. Policy framework, strategic shift of key pillars, state funded access. For as I discussed earlier, in Punjab we have started the non-factor therapy prophylaxis to our patients. So regarding this, budget is not provided by Government of India. It is provided under the budget for non-factor therapy injection emicizumab provided by Department of Health and Family Welfare Punjab under essential drug and basic coverage. The factor 8, 9, 7 and APCC fiber are added in the state essential drug list and provided in all district hospitals of Punjab. Digital supply chain, we had developed a iCare software, state software, in which we have done the registry of all patients and the real-time monitoring, dosing, all the supply chain we have provided to the district hospitals, all are registered in the software. Specialized referral, complex surgical cases, life-threatening bleeds episodes are systematically they are referred to PGMR Chandigarh. So where as per their demand, we will provide the factors at PGMR Chandigarh for surgical cases, intracranial bleeding, life-threatening bleeding. We provide the hemophilia drugs to patients which are admitted at PGMR Chandigarh. Flexible procurement, state procurement shifted, we have shifted from standard SHL standard half-life factors to the extended half-life factor. Non-factor therapy, we in the state of Punjab we had developed a non-factor therapy policy framework which include pediatric age group 1 to 18 year. इन पेशेंट्स को ज़्यादा प्रेफरेंस दी जाती है जिनका वेट कम हो, 50 kg से जिनका वेट कम हो उनको ज़्यादा प्रेफरेंस दी जाती है. हाई इनहिबिटर टाइटर, inhibitor positive and have more than 7 treated bleeds with APCC amounting of 100 IU per kg per bleed. Life-threatening bleeds such as intracranial bleed, abdominal bleed having pseudotumor etc. given the utmost priority. The patients who consume the most budget of other hemophilia 8 or our inhibitor APCC or factor 7, they are consume the maximum budget are shifted to the injection non-factor therapy injection emicizumab. The inhibitor state of the patient should be confirmed by the standard labs such as PGMR Chandigarh. Those patients are shifted to the prophylaxis treatment. Currently in the state of Punjab, 20 patients of hemophilia A and with inhibitor meeting the high priority criteria as per the policy framework has been put on non-factor therapy injection emicizumab as as I said earlier, the budget for emicizumab has been not provided by NHM Government of India. So the budget is provided by Government of Punjab under Essential Drug List. Initiating factor therapy for more eligible patient with approval of ministry in the stepwise manner. The patient which we put on injection emicizumab, the approval is get from the Department of Health and Family Welfare at the level of Health Minister of Punjab. After that, we put that patient in on injection emicizumab by securing the patient whole annual budget and all the vials which will be consumed by the patient in a whole year. More focus on the children less than the age of 18-year-old. Hemophilia patients of Punjab requiring surgical intervention management of life-threatening bleeding are referred to Tertiary Care Center PGMR Chandigarh for specialized center. For factor are being provided to such patients at PGMR Chandigarh on demand. As in this format, the PGMR Chandigarh will send me a request letter in which they will mention the name of patient, from which district the patient belong to, which district, type of bleed, and the number of dose the patient required for how many doses. Everything is mentioned in the reference letter. As per that, we will provide medicine at PGMR Chandigarh to the patient. For patient monitoring, we had developed a iCare software. This is a state initiative. It has been implemented for the online registry of hemophilia and thalassemia patient. This software enables real-time monitoring of drug supplies, treatment schedules, and service utilization, improving the efficiency and effectiveness of the patient management. On the other side, also we are entering the patient our patient data on National Sickle Cell Anemia Elimination Portal. It is under process. We are adding the patient data also on Sickle Cell Portal. This is the pattern in which how we enter the our patient data on iCare software, where the mention you may say the name of the patient, what kind of disease he had, or everything, a patient appointment, patient report, patient health report, new visit, when the patient have to visit to the hospital for next visit, list of all visits, record patient, if patient is died, the patient record also maintained, patient unique ID, everything is maintained in this iCare software. Capacity building, state level training conferences are being organized in collaboration with PGMR Chandigarh and state medical colleges faculty time to time for capacity building and updating the knowledge of nodal officers and paramedical staff involving management of hemophilia patient. Promotion of physiotherapy. इन हमारे जितने भी डिस्ट्रिक्ट हॉस्पिटल्स हैं वहाँ पे फिजियोथेरेपी सेंटर्स हैं. सो एग्जिस्टिंग जो हमारी फिजियोथेरेपी सेंटर है वहाँ की मैन पावर को हमने लेटर इशू किया है कि फिजियोथेरेपी must be available for all hemophilia patients, and their hemophilia patients are given the priority for physiotherapy who require. The kind of challenges we are facing in our state for implementing the program. So first one, all the state must be following this challenge. No clear guidelines from Government of India regarding coagulation disorder management and treatment protocol. Crunch of trained human resources. No dedicated infrastructure. Cost of treatment. Budget constraint for regular availability of factor and prophylaxis. Lack of adequate diagnostic facility, which are going to we are going to improve. Morbidity reduction, prenatal counseling and detection, inclusion of new modalities of treatment, capacity building of staff. As we do the capacity, there are no dedicated staff in ICHS centers. So जैसे हम staff की training करते हैं, regular staff है, after 1 or 2 months they will be shifted to another wing. So this is the major issue we are facing. Rehabilitation centers and skill development and job reservation for these patients. Anti-hemophilia supply chain challenges. No valid RC for factor 8 SHL as not available. Companies are not participating for tenders of SHL. Ultimately, we have to shift to the EHL for factor 8, which for which the valid RC is available. Partial deliveries or reliance of few suppliers has significantly disrupted the supply chain of recombinant factors. Global equity in hemophilia care. Excess gap remains significant in low and middle income countries. Future effort will likely to focus on expanding access of low-cost therapies, partnership between government, NGOs and pharmaceutical companies, plasma fraction facilities and local manufacturers may be enhanced. So, policy and advocacy for universal health coverage, national registries and integrated hemophilia programs will be crucial to improve the outcome and reduce the morbidity globally. Hemophilia care is going a transforming era with promising therapies and technologies. Continued innovation, equitable access and comprehensive care are essential for improving the patient outcome worldwide. So, thank you. This is the scenario of hemophilia in the Punjab.
Thank you so much, Dr. Rubinder Kaur, for such an engaging and insightful session. I now invite Dr. Joseph John, sir, to felicitate her for that excellent session. Our next session is relatively very engaging and a very model state which is doing quite a difference. So, state-led innovation sharing lesson shaping the future in Tamil Nadu by Dr. D. Biola, National Health Mission, Tamil Nadu.
So a very good morning to one and all present here. So now I would like to share some of the state innovations and also some lessons we have learnt in Tamil Nadu. I'm a senior consultant working in NHM looking after blood cell for the past 8 years. So the total population in Tamil Nadu is 7.21 crores with the census 2011, and also now the current population is 8.41 with the annual population growth rate. We have totally 38 districts and we have hemophilia A patient 1750, hemophilia B 304 and inhibitors 244, and we have integrated centers for hemophilia and hemoglobinopathies which is 10 in number. Okay, so hemophilia A is 1750 and hemophilia B is 304, and also inhibitors we have 244, and we have 10 integrated centers for hemophilia and hemoglobinopathies. These 10 centers are being established in the medical college hospitals. So integrated center for hemophilia and hemoglobinopathies. In 2018 we had our first 5 centers which was ICH, Coimbatore, Salem, Madurai, and Kanyakumari. So here the general medicine and pediatrics department come in. It is attached to a general medicine department or pediatrics department. It is a one-stop center. So any hemophilia patients, any TAL patients, any sickle cell patients, they can directly walk in these centers and they can get their services there. If it is attached to a pediatrics department, the PGs from general medicine department has to be there, and also it is a staff nurse led model. So 24/7 hours staff nurse will be available. Apart from this, we have all the medical colleges treating for hemophilia. Factors are available in all medical colleges, and for treating thalassemia also blood banks are available in all medical colleges, and also district headquarters hospital also. So this is a district-wise hemophilia patients available in our state. And services offered in our states are, as already I told, we give on-demand therapy for 2,200 patients, and 250 children are in prophylaxis. And also we have established 3 coagulation labs. One is RGGH, Coimbatore, and also ICH. And we are giving training for the pediatricians and also general medicine. And we have a state registry, and also we have developed a state-specific app to monitor the drug supply. So process flow, coming to the process flow, we have nodal officer at all medical colleges. That is, we have 38 districts, 32 districts have medical colleges and 6 have headquarters. We have a nodal officer at all levels, and also if nodal officer is present, 2 nodal officer will be available, one for pediatrics and one for general medicine. But overall we have 1 nodal officer per district. And also line list of the patients is available in all medical college hospitals and also DEIC. And the MSO, medical stores officer, who maintains the drug in the medical colleges. And also the program is monitored very closely at the state level. With regard to procurement, we have TNMSC, Tamil Nadu Service Medical Corporation, which is established in 1995. So they fix the rate contract for all the drugs and equipments. So we have a very strict process, technical evaluation committee, financial bid opening committee, everything. They have even the drug committee, which will be gathered once in a year, and also they have board members. In case if the tender is over, that is in case the RC is expired. So if we want to extend the the rate contract for the 3 months or 6 months, the committee decides, the board committee decides. And also with regard to hemophilia, the indent is given from the medical college hospitals. From the medical college hospitals, it is being collected in the respective institution, DME and TMS, and then it is through them it goes to TNMSC, and from TNMSC they issue the there is PO copy, purchase order copy. So within the issue of purchase order copy, within 60 days they have to deliver. In case if they don't deliver, they are entitled of getting penalty, and also if they do any fraudulent something, they'll be blacklisted. And also this we have a passbook system which monitors the drug in the districts. So this is a copy of a passbook system which was downloaded in February. So if we take the program for, there is hemophilic drugs. So the total, this 37 districts, and the total drug spent was 39 lakh odd, and 51 lakh is available. So if you see the 00, so the drugs are being shifted among themselves with the instructions from the state. So with regard to hemophilia, so from 2015-16 we are getting budget from NHM. So the over and above the spent drugs will be given from the state budget. For example, 2021 the the procured value was 46 crore. We had only 15 crore from the NHM budget. So remaining will be supported from the state budget. And coming to prophylaxis, we have already 250 children on prophylaxis. So that budget will be directly given from NHM to TNMC. So we have the monitoring, as already told, we have monitoring and review system from the state level. and prophylaxis every third week we monitor, and also on demand is being monitored at the each directorates level. So already I told there is a district early intervention center. So I think most of the states would have this district early intervention center. This is a very good concept. Actually, we have the line list of each patients in the district early intervention center. District early intervention center, since some officials may be new, I would like to tell. The RBSK team screens, and this is a referral point. DIC stands as a referral point. So in Tamil Nadu, we had a government order stating that all the hemophilics and hemoglobinopathies patients should be registered in the district early intervention center. We have a very good registry with the Aadhaar card, so with the Aadhaar number enrolled, so that no duplication occurs. And also we have a set of HR, nearly 12 HR is available in the district early intervention center, with the data manager and data entry operator. So with them we can have many works done. So now coming to National Sickle Cell Elimination Mission. So this portal, first this app was launched only for sickle cell in 2022, October 2022. Now recently they have added thalassemia, and for the past 6 months they have added hemophilia. So it is mandatory to enter all the hemophilic cases in this app. So 7 states who are already in this portal, it's okay, but other states definitely you have to enroll in this app, so that you will get your drug budget from Government of India. So three to four flaws are there in this. You cannot take the line list from this portal, number 1. Number 2 is you have to put the diagnosis as if the patient has been diagnosed in 2000, but since the app has been developed from 2022, you have to put the diagnosis date as 2022, any date after 2022. That is number 2 flaw. And number 3 is that that is after 40 years you cannot make entry. So after 40 years, since the National Sickle Cell Elimination Program is for 0 to 40 years, so once we put the Aadhaar number, everything gets auto calculated, so that you cannot enter the hemophiliacs. So you also don't have the inhibitor that is separately. You have to put everything in hemophilia A and hemophilia B. So we have entered almost 1945 out of 2400. Nearly 200 cases are that above 40, and also some cases, some medical colleges did not enter because of the inhibitor issue. So we have already given instructions to put in the hemophilia A or B itself. So this is one of the important, since already I told this is a key. It is one of the indicator of the key deliverables. So key deliverables is a benchmark of each program monitored by the Government of India. So last time we had nearly 185 key deliverables. Now the key deliverables of NHM has been reduced to 65. So 2 key deliverables related to blood are percentage of thalassemia and hemophilia patients entered in the portal, National Sickle Cell Portal. That is one of the key deliverables. And next is the treatment of sickle cell anemia, which most of the states would have done. So coming to this PIP sheet, so we have HSS 154, 2.154, which has the drugs, the budget for drugs. So you can procure for your on-demand prophylaxis, everything you can procure in this drug budget. And also you have 158, which supports for the diagnostics. So diagnostics, we have budget for coagulation lab. We have 30 lakhs we have already proposed, and we have also got approval. So next is Nalam map. This is a state-specific app to monitor the delivery of drugs in each medical colleges. So we have around 2,305. There is people being enrolled in this Nalam map. And so we have the 2 levels of entry. There is patient registration, which will be done by the doctor's mobile using this app, and also the drugs will be entered in the MSO. So it has been very closely monitored. And also once a patient enters, the patient ID will be put, or they can just scan the ID, and immediately the OTP is generated. So then the doctor prescribes, then automatically it goes to the ward, and then the stock automatically gets reduced. So this is in the primitive stage. So we'll be shortly launching throughout the state. So this is patients being registered in the Nala map, and also we also do capacity building. So annually capacity building is done 2 days, combining the hemophilia and hemoglobinopathies. It is an integrated training. So we call the general medicine and the pediatrics department professors from each medical colleges and headquarters. So they are trained. And recently we have signed an MOU with CMC Vellore for the bone marrow transplant. One of the aspects are to engage them as a resource institute in our trainings. So in insurance, we have 5,000 rupees covered for each hemophilia patients per month. So now we have also written to the project director TNHSP, since the tender is going to be over. So new tender has to be will be released in short. So for our state, we were requesting that is for inhibitor testing. You can there is 8,000 rupees, genetic test 20,000 rupees, and also for inhibitor patients they have to increase the amount. So we have written letter to the project director. So mostly, in short, expert committee meeting will be held and it will be through. And coming to disability cards, each medical college gives the disability card in a campaign mode if there is a long pending. Now all the pendings are being over, and now they have weekly they have this disability card distribution. So the individual has to come. They have to apply online. The person from disability department also will come, and also we have the DAC as a coordinating person in this. Since different department come, ophtol, ENT, everyone will come, and so based on the disability of the patient, and also above 40 years, we also ensure that 1,500 rupees are being given to the patients. This is being followed by the social worker who is available in the district early intervention center. So physiotherapy services, already a physiotherapist is being available in all the DEACs. Totally 39 DEACs we have, so physiotherapists are being already engaged, and also the integrated centers, 10 integrated centers, all the children who come twice a week, so they are being benefited, and also the adult patient, also the DEAC does the physiotherapist services for them, and also field visit. So from the state we take field visits to see whether everything is in place. So Hemophilia Day celebration, generally we issue instructions from the state level to the districts so that this Hemophilia Day is celebrated in a proper manner. This year alone we could not give because of the election code of conduct. So we also ask them reports. So definitely all the medical colleges will have Rangoli competition, quiz competition, and also patient support groups will be engaged in the DIC. So the support from HI5 we get is that human resource for high load centers they provide, and also app entry. For in DIC they'll enter the app, then for how to call everyone in a one go. So in a month's time their support was very useful so that we could complete our app entries. So coordination for disability certificate also it is being done for the hemophilia patients through the societies, and also patient support group, emotional support. Those who come for treatment, we also encourage them to be registered in the society, hemophilia society. So future plan is that already the state specific drug gap will be rolled out throughout the state. Capacity building with the CMC Vellore as one of the partnership, and periodic training for all the healthcare workers, and also new children, 150 children we are adding new this year in the prophylaxis. So 400 from 250 we are increasing prophylaxis to 400. So take home message is that so state fund, if you don't get state funds, you can actually approach NHM, National Health Mission. You have a separate blood cell, definitely you can get your proposals through. So we have also got many funds through NHM. So definitely I encourage states to propose in National Health Mission in the PIPs. And line list of patients, having a nodal center like DAC, all your line list can be maintained in the DAC. And during that is, and also drug monitoring, you please you opt for any digital platform. And also capacity building is very important, and also engaging NGOs like Hemophilia Society and any trust working for hemophilia will be more of useful for doing our program in a successful manner. Thank you.
That was a truly enriching session. Thank you so much, Dr. Viola. May I now request our Vice President Finance, Mr. T.S. Vaikuntham sir, to come forward and felicitate her. Music. We have a very dynamic session upcoming from Dr. Joseph John sir. He will be talking about need for guidelines for hemophilia and HTC grading. Dr. Joseph John sir is from CMC Ludhiana.
Good morning, everyone. It's a pleasure to meet all of you as the Hemophilia Federation of India representations from across the country and the nodal officers where all of you are collaborating and working. Prem had asked me to present something on the HTC requirement for HTC grading and the need for guidelines. So I put together some slides just to embark upon and to bring about the importance of standards and the quality aspect of it in hemophilia care. We talk about quality all the time. This we all understand. Okay, for a population of India, we should have at least 1.4 lakh, and we hear that again and again on all meetings. I wouldn't go through that. Why do these challenges exist is because of low awareness, limited care, inadequate and interrupted factor supply. Although it is much better than 2008 onwards, till that time we were short of supply of factors across the country. Now things are much better in the last 15 years. Of course, these are things we understand about socioeconomic barriers. So I want you to participate in the discussion. As a teacher in the medical college, I like thinking process alongside. What is it that which comes to your mind when you see this picture there? The words which come across. It could be chaos, it could be disruption. Sorry? Disorganized. Okay, any other words which will come in your mind? Chaos. Many things can come in your mind. How could that be better? And we all despise this kind of a situation to be in the morning when we have to come. The question is, why did this happen? Do you think any one of them didn't know how to drive? All of them knew how to drive. All of them knew the rules. But what was the problem? Knowing driving is not enough, but having no traffic rules and no signals and no lanes defined and implemented was the question. So each driver was his own judgment, and it caused chaotic situation, and it is a predictable situation. If what it shows is that if there are no rules and the no rules are not implemented, chaos or disorganization is likely to happen. Healthcare without guidelines is no different. Everybody knows how to treat. Nobody knows factor 8 has to be given, But how to give, when to give, which situation is to be given, how to utilize it in the appropriate manner is the situation. So obviously we need to have a structured guidance, and patient care becomes otherwise extremely variable and often unsafe. And it's extremely important to have this timely application of it, and of course the time and the speed at which anything is delivered matters the most. So we understand that we need guidelines in hemophilia. How does that help? Of course, standardization of care, as I mentioned, and quality of care irrespective of the location. It should not be that person in Tamil Nadu gets a better care than a person getting in Jammu and Kashmir. All of the doctors pass MBBS exams, and the care in these meetings is reasonably standardized in discussions, and that can be, of course, given out. But what we need to understand as a healthcare professionals is, instead of an individual or a doctor-driven care, we need to work towards a system-based care. So even if we are sitting here today in the meeting, if a patient comes to your hospital, things are taken care of because a process is in place and it will be followed. So ensures minimum acceptable care. We are not expecting the highest form of care which Mayo Clinic may be providing, but we must ensure that at least a minimum is given within the standard in the resource limited settings. Of course, that has its bearing. The hard endpoint is the patient outcome, and what the patient says and patient feels and experiences becomes more than just we reduce the bleed alone. So this is what we want. The number of cars and the number of people and the number of things in that area is almost the same, but because there are signals, there is rules are implemented, things are much smoother. And you would all have realized that when we go abroad to any other country, you will feel so bad and think that why can't we be like that? So WHO guidelines are there. WFH guidelines have come in 2020. It is getting revised now. But we must understand that even though there are 12 chapters, countries have to evolve in what is applicable in their country and have a standardization. That is why these meetings, which is called by IHARD or HFIs, will have a lot of meaning in understanding and standardizing our care. This is one of the guidelines from Australia. Similarly, that is standards of care, there are principles of care. Now principles drive the standards. At least we do not have the principles of care, we cannot drive the standards. The Europeans brought out the first principles of care document by IHARD, and it is an interdisciplinary committee which brought together the clinicians and said, okay, at least we have these principles. Principles should guide the standards, which would then guide the outcomes. So again, this was the consortiums have to endorse this. WFH then endorsed it. Asia Pacific group said that okay, that is the European guideline. It is all of that is not applicable in the Asia Pacific region. We need to have some modification. It is not that completely modified. And therefore the Asia Pacific came up. And why should it be different? Because we have a varied healthcare system. The healthcare systems in the US is driven by or other countries are driven largely by the government sector, and we are out of pocket, or only a few hemophilia diseases are being covered by the government now. So there is diversities in those. So that actually makes us to say that we must have our own guideline inspired from the original guideline. Now what we have an interesting phenomenon in the country is called the disability paradox. So if you ask the quality of life assessment for a patient in India, he would have the similar quality of life evaluation about himself as compared to some other country with much less joint disabilities. That's because we have adapted, we've learned to be happy in an environment we are in because our expectations are not high. But if our expectations go high, then the quality of life, we start thinking that we should have been there and not here. We also have personal social impact. This was a qualitative study we did. We found out that there is a transformative resilience in the patients of hemophilia in India. In spite of the problems of not having prophylaxis, they are able to cope and adapt as human behavior says. and in spite of various other problems we are able to cope. So of course the hemophilia care in India then has to be slightly different from what the World Federation demands, and we need to have our own guidelines which has to be directed. So that is why HFI has brought in, and it is bringing in guidelines. So first point I am mind to make is the importance of thrusting the importance of having a guideline for hemophilia and having a consensus to follow that. Then comes the point of standards of care and quality of care. So what is standard, what is quality? Standards are essentially we predefine and say by evidence we need to have these met. That is minimum acceptable. Quality is how are we fulfilling that and are we reaching that, and that's the point at which, that's the tension always we have. What's the standard we want, what's the quality we are delivering, are we delivering what we are supposed to deliver? What does this mean to us? The mark on the helmet or the FSSAI? Anybody? The quality of the helmet is based on ISI mark, and therefore an external body is saying this mark means reliable by it. How do we do that in healthcare today? What is a mark of quality in healthcare today? NABH. You're right. So NABH is the mark. Okay. Now, let us say healthcare has NABH. NABH has got excellent standards in blood banking. It has brought in dental care. It has gone in nursing, and it is now specialty wise coming in. There is a QCI which is movement which is happening for grading the hospitals with NABH certification or accreditation, and then grading them and saying, because all NABH certified hospitals are not the same. So you can have an NABH certified hospital as a primary care, secondary care and a tertiary care, but what we are delivering is different there. Imagine a similar situation in hemophilia. How would it be accessed then the care based upon what we can? So this is the spectrum of problems based on affordability in the country today, from inability to afford factors to occasional FFPs to some factors and of prophylaxis. In terms of accessibility of the care, you can have absolute ignorance to arrogance to joint deformities to hemophilia clinics to well-preserved joints. So we have a spectrum of care being given for hemophilia. Now comes the levels of care. So this was one of the things we were trying to put forth to say that who decides a hemophilia treatment center which is capable to do, how do we evaluate a hemophilia treatment center? So not all problems are managed at the same level. If you have an acute bleed, it is managed differently. If you have need of a surgery, pseudotumor has to be different. All hemophilia treatment centers are not the same. So we have healthcare, we have primary healthcare, secondary healthcare, tertiary care. If you look at neonatal ICU, some of you must be pediatricians here. There are level 1 to level 4 ICUs for NICU based upon what can be delivered. Now comes a situation where the Europeans talked about EHTCs and EHCCs as guidances and kept guidances and criteria for that. I wouldn't go through each one of them. But the interesting part is that we did one survey a few years ago and found out that about 85% of them did not even fit into either of it. So this is now an HTC which is in the no man's zone. It is not EHTC, EHCC or EHCCC, Comprehensive Center of Excellence. So where do we then say it is not an HTC? So there is some words, semantics were different, and this was a study to say that okay, how many people are there, etc., and said nothing. 85% of them fallen out of that either of the criteria. This was a study which was published last year, cross-sectional survey from India, looking at all the facilities in the country and saying, can we risk stratify and say there are some levels can be achieved. In this, unclassified was 55 if you used IHC criteria, European standards. So we said some HTCs will have labs, some of them may not have a lab. But let us not say because you didn't have a lab, you are not an HTC. You're still giving care. So we said, okay, 1 to 4 clinical and lab separately. And availability of clinical services, if you see, you cannot have all of them in all the centers. There's still some reds which you cannot meet up. Same with the laboratory. And therefore, we said we can have level 1 to level 4 clinical care. We can go through each one of them, but I wouldn't read through that. But essentially, level 1 can manage acute needs. Level 2, chronic joint care. Level 3 can do surgeries and prophylaxis, and level 4 can add advanced treatments. So you can now say which level is my HTC in the clinical care. You may not have a lab, but you can outsource the lab and still have a level 3 clinical care. And same with the lab, with the functionalities, you can do basic clotting tests, factor assays, inhibitor assays, and molecular diagnostics. So you may be a level 3 clinical care with a level 1 lab, good enough. So that then we wrote to EMJ, European Medical Journal, and they were quite happy to include that as a publication there. Essentially, in any care sector, wherever you are, you think of 3 things. 1, structure. Do I have the structure to conduct the care? Second is, do I have the processes and services and activities for the care delivery? And last is, what is the impact? 3 things: facility, processes, outcome. Think these 3 domains and say, where must I improve? So the advantages of this is you can have optimal patient care, organized referral pathways. So level 1 will say, I'm level 2 today and I want to send a patient to level 3, send them. So nothing to be feeling bad that I'm not level 3, because this is a facility I have a level 2, I will send to a level 3 facility, and collaborative networks can be created. The advantage is resource allocation. Imagine from a state level, you now know as a nodal officer, in my state there are 25 district hospitals and 5 of them are level 3, 6 of them are level 2, the rest are level 1. Good enough. How do I go to the next year? Can I improve the level 1s to level 2, level 2 to level 3? Is an aspirational improvement mechanism, incremental investments can be done there. When you policy and healthcare planning wise, you can have the levels used, and it can be taken up to the ministry level and say, for the government of India, India has today 291 HTCs as of now. Not all of them have uploaded the data. I had as a registry or a register which is going on, where to know what is the levels of these centers are. So it's important for the government to think that, okay, we want to have X amount of level 4s, X amount of level 3s, level 2s in each state. Easy to deliver them. Quality improvement can be linked to a KPI. KPI is a key performance indicator, which is now going to come in when you have NABH accreditation process happening in. You would know how many of your patients are on demand, how many of are on prophylaxis, what is the ABR, are you submitting data to the registry, all that then come as a KPI. So pathway for accreditation in the sense, tomorrow if Government of India wants to say that if I have to give factors to a X center, you should have had a certification done, not as a regulatory mandate, but as a compliance to get further subsidies or further support of factors. That can be a movement which can be done through the HFI or IHAD and come together, put in a document together. Some work is being done, and all of you coming together and giving your inputs can become a fantastic document, and we can actually go to the NABH and say HTC standards for NABH, and they are easily ready to accept it, and we have spoken to a few people as well. Europe have already started it. It is not a mandate or a regulatory mandate from the government, but a certification, a self-check mechanism. Otherwise, how do I know am I on the right track? With that, I'll conclude saying that HTC stratification is not just a classification for the name's sake, but it is a roadmap for equitable care and a quality improvement and improving our systems. Thank you. Any questions? Okay. If any questions, I'm more than-
किसी को कुछ पूछना है, this is best time, you know. Dr. Joseph John sir is a pioneer in creating guidelines on the world level. तो आपको कोई भी क्वेश्चन है अपने स्टेट के रिगार्डिंग या फिर हाउ वी कैन मेक फुल यूज ऑफ गाइडलाइंस, तो प्लीज़ आपके क्वेश्चंस.
Okay, so in the amount of time I may.
Yeah, sure.
Thank you so much.
Sir, just a second, sir. We will like to felicitate you. Yeah. So thank you, Dr. Joseph John sir, for such a engaging session. And एक की पर्सन ने मुझे आके बोला कि सर का एक स्पेशल थैंक्स करना कि उन्होंने गाइडलाइंस जैसा कठिन विषय हमें इजी टर्म्स में समझाया. सो थैंक यू सो मच सर. नाउ आई रिक्वेस्ट मिस्टर रजनीश जैन, अवर CEO, to felicitate Dr. Joseph John sir. Thank you, Doctor. Sure.
Sorry? Yes, yes.
Hemophilia care, what are the different KPI indicators you have devised?
Correct.
And is there any KPI indicators present at the HFI or the national level or the international level?
Correct. As of now, to be frank, we discussed with the WFH, the delegates who had come for discussions also. There is no KPIs which have been promoted as of now, except for patient reported outcomes, PROMs, which we call. It's not that these are the only 10 KPIs or 5 KPIs you should have. KPI is something which you have to develop based upon your need. If I'm doing well on certain things, I may not want a KPI for that. I want a KPI for something which I'm not good at. So if you look at the NABH versus guidelines, one of the KPIs is the medication errors. So what, I mean, I'm just taking from that example, you can say how many of my patients I am able to deliver full dose of factors. Now, some of the KPIs you cannot meet at all because prophylaxis, I want 100%. Unless I have the factors, I cannot meet 100%. Therefore, that alone cannot be a KPI. But if I had surplus of factors and my patients are not on prophylaxis, then that becomes a KPI because the resources are already met. What we can do is, are my patients on regular follow-up? Follow-up percentage can be a good KPI. That could be various reasons. So then you go to the root cause analysis and say, why are the people not coming for the follow-up? Is it because they have they are far away, or is there any other things which we need to improve? So that's the idea, is that it is not becoming a draconian rule to control somebody, but to find out the reasons for non-performance and improve. One to four, yes. Yes. Your mic, so that everybody can hear something.
There are deficiencies in the primary care. I know
Yes.
it. There is deficiencies in secondary care. But at the tertiary care, there is a lot of facilities, there are a lot of inputs and a lot of funds are being provided.
So Mike.
Why not we can devise the KPIs for the tertiary care level?
Absolutely. If the KPI should be based upon the levels. You cannot evaluate, it's like lightweight boxing and a heavyweight boxing. The categories are different. The prices are different. So you have to have KPIs different for the tertiary care and the primary care. So you say, I'm at primary care, this is all I'm expected to do. It is not possible with the resources I can do. So you cannot be evaluated on the same. You're right, absolutely right. There has to be a distinction between the KPIs across the cares.
Thank you so much, Dr. Joseph John sir. Big round of applause, guys. So we have birthdays, right? हम सभी के birthdays आते हैं. Every year we have to celebrate those, right? कि हम चाहते हैं कि उसे हर कोई हमें उस दिन कहे हैप्पी बर्थडे सौरभ, हैप्पी बर्थडे विजय, हैप्पी बर्थडे राकेश, या ऐसे हम जनरली परसेप्शन होता है. तो वर्ल्ड हीमोफीलिया डे मैं भी इसे समझता था कि एक हैप्पी बर्थडे जैसा है कि हम सभी उसे सेलिब्रेट करते हैं. बट इन लास्ट 2-3 years दैट डे हैज़ चेंज्ड माई परसेप्शन. इसे मैं किसी सेलिब्रेशन से ज़्यादा मैं एक बेंचमार्क समझता हूँ. हर साल हम कितना प्रोग्रेस कर चुके हैं लास्ट ईयर से, ये समझने का मेरे लिए यह दिन है. तो इस अगले सेशन के बाद मैं आप सभी के पास आऊँगा और किसी 3 लोगों को पूछूंगा कि आपके लिए वर्ल्ड हीमोफीलिया डे का मीनिंग क्या है. तो आपके आंसर्स आपके पास रेडी होने चाहिए. एंड नाउ आई रिक्वेस्ट अवर नेक्स्ट स्पीकर, डॉक्टर चेरी गुप्ता मैम फ्रॉम NHM हरियाणा. She will be talking about how Haryana is innovating, how Haryana is progressing. So over to Cherry Gupta ma'am.
Morning, everyone. I take up this opportunity to thank the HFI for giving me an opportunity to present before you some of the good things that Haryana is doing, blood cell in Haryana. Although that is not much of it, and we are over here, I feel we are way back. But the thing is that the government, as I pointed out yesterday evening also, that we are trying our best, and we are proposing to the government. And one of the major points in this PPT also I have already shared, that a budget head should be created, and that is the crux of it. So I'll not take much of time. So as we all know that hemophilia is a genetic disorder, and the females are the carriers. It's presented only in the males. Haryana, the objective of the blood cell is to provide first of all, provide the basic anti-hemophilia factors, that is the management treatment to all the patients. Currently, patients' number has increased this year from 864 to 1019. This was a tremendous change that has been in screening and diagnosis of the new patients in the financial year of 25-26. And in this hemophilia A patients have increased about 550 in number by the carrier testing from the index cases going backward. So in prevalence of talking about the prevalence, there is more of prevalence in the western districts of Haryana rather than and the southern districts of Haryana rather than in the north. So we are having about more than 50 patients in the 5 districts of Haryana. That is counting to about 97 to 67 patients about that. So this is the kind of a variability that exists. And in this, there is more of the adult patients, and children are being diagnosed. That is a thing, but there should be more of children. But probably there has been a shift, and I have to just analyze this thing. The facilities being provided. In this, as I've seen that in Tamil Nadu, ma'am has already covered many of the things, and I think it's a basic strategy that is being followed in every state also. So it is all with the NHM and the blood cell and the blood transfusion services. It's a combined thing that goes on in our state of Haryana. So in Haryana, we provide the blood and blood component facilities to all the patients free of cost, and all the factors, that is factor 8, 9, FIBA and factor 7 are being procured through the Haryana Medical Corporation. That is through that sum. And it is on the tender basis. If the tender is expired and there is no RC available, then the RC of the neighboring states is being considered till that the second tender comes in process. And although one of the major things is that Haryana has included all the factors in the essential drug list of the state itself, because as it was discussed yesterday, it is not an NHM. So they don't provide cost-wise budget. From the Haryana is not getting the budget for the factors from NHM, but since it is in the EDL, state has owned up to provide treatment to all its patients. But still there are cuts, and there are levels are there. So sustainability of the supply is definitely becomes an issue at times. So my request to the all the senior members over here, so that NHM there should be a specific head for the procurement of the medicines, not as just as Dr. Bila has discussed about 154 and 158 heads. That is about the generalized. There should be a specific mention of that head, because then states will have to propose. The NHM will ask that what budget you have proposed, and they will have to give it, be it a starting point only, because then it becomes easier for everyone. Then Haryana is giving a free transport facility based upon the disability cards, which are being issued from the district levels, by the civil surgeon at itself, and from there the patients can travel freely with one attendant in the Haryana transport buses. And then there is for the treatment purposes, for the patients to go and come back to the home centers, to the treatment centers, there is a free ambulance pick and drop facility that is being provided. And plus for the if patient goes out of Haryana, they are registered in Haryana, but if they go out of Haryana, in case they have to purchase the factors and they are not able to, they have to incur some costs, there is a policy of free reimbursement of rupees 80,000 subject to the prescription and the bills produced. But it is not applicable for the elective part. It is only for the emergency part if they're out of state and they have to procure and get themselves treated. Then only they can be given about this. One of the benchmarks for the state is that out of the 22 districts, state has one integrated center for hemoglobinopathies and hemophilia in each of its districts. That is 19 of them are functional and 3 are under process. So it will be done within 3 months. So over there, this is a one checkpoint and one stop center for all the patients for hemoglobinopathies, that is thalassemia as well as hemophilia patients. They'll come over there, they get their checkup done from the physicians, from the pediatricians, and the physiotherapist visit over there to tell them about the physiotherapy and the exercises, and the lab attendant is there to take the samples for the patient. The patient doesn't have to go to the lab itself. The lab attendant has to come over there and take up the samples, or it will be sent by the staff nurse. Basically, one nodal person is there and one staff nurse is there, just as the model of the staff nurse center, the center being led by the staff nurses, as Dr. Bela discussed for Tamil Nadu. And this gives a build up for the confidence for the patient, because they're frequently going here and there in the civil hospital, that the hassles are reduced, and so they have a better confidence in the system of the district hospitals. They have a better treatment options, and they have a better quality outcomes. They have a fewer admissions and fewer infections also, that hospital acquired infections which can be around the clock they can acquire, but that gets decreased, and they know the place where they have to go. So it is very because all the districts are going to have it, so it's a great thing for us. This is some pictures of the centers. This is IHC Panipat, Kurukshetra. Their patient records are being maintained in the form of the patient diaries itself. One of them is available with the patient, one of them is available with the staff nurse on the duty. Faridabad and Jeend. This is the Panipat, Panchkula. The third one is that Haryana government has introduced a disability pension, that is a financial assistance to the patients of hemophilia as well as thalassemia. Presently, there has about 3,000 rupees per patient, and the magnificent part about it is that it is not age related. The government has removed this clause that there should be age of 18 years. It implies from the very birth of the patient, from the very point it is diagnosed, because it's a genetic disease. And second part about it is that counts the patient's own income. It is not about the family income. The eligibility counts it as patient's own income up to 3 lakh rupees from all the resources. It is generally, in the disability pension, it is always from the family sources accounted. Thirdly, our CM sir Honorable CM sir had announced about that if a patient of hemophilia or thalassemia is having any pension under any other clause, but this pension is not to be discontinued. So patient have to have a double benefit of it. And in this way, the patient are being given a multifactorial confidential building in the government system, so that they do not have to look upon someone and they can go ahead with the quality of life. Presently, there have been till December. It was launched in on 5th of December 2024 and amended in March 2025. So till 31st of December, 232 hemophilia patients and 605 thalassemia patients have been given this assistance. And they have been identified under the eligibility criteria, and out of it is a benchmark figure for us, because total of thalassemia patients have been 1400 and 1019 patients for hemophilia, making up to only 2500, and many of them are not eligible also because the people don't come up also patients. So that's a benchmark figure for us. Yeah, we have all been talking about the prophylaxis over here and about the non-factor therapy. So Haryana is into it, that it is initiated the process for providing the prophylaxis as well as the non-factor therapy. But our state needs to have a policy amendments, because if we do not go for a policy amendments, then there can be disparities in providing the treatment. So to have the uniformity in the things, just as Joseph sir had told in the previous lecture told us about the grading of the HTCs. Similarly, for the policy part, our government is a better strict. So after it is being done, after looking up all the ups and downs again of these introduction of the factors and the non-factor therapy also, we are going to amend it out, and I hope that it will be launched this year and it should be included, because as going through the amishizumab, we found in some cases there are some essays that to be done. So there are only 2 centers, as we know in yesterday, in Mumbai and only in CMC Vellore, and we have at a PGI Chandigarh also. But then from all over the Haryana, if you put the patients of all the patients or even inhibitor patients, that counts to be 31 in Haryana. So if we put them on amishizumab, and then the patient levels have to be monitored. So we are working upon it and looking about the pros and cons of everything, so that it goes for flawless policy. Though things will come up, but still we want to go ahead and will be doing up this year. So, one more thing, in the disease sickle cell portal that ma'am had discussed, I wanted to log in that should be disease management module needs to be added in that portal, because there is a lot of disparity when we want to monitor how the factors are being given, how the treatment is being given to the patient, and that is giving not a proper real-time monitoring is not possible, although it is already there for the sickle cell disease. But for thalassemia and hemophilia, there have been additions. The portal needs a modification. So that's all. Thank you so much.
Ma'am, please. That was a really brilliant session by Dr. Cherry ma'am. It was very informative and engaging. Now, before we start any questions, may I invite our EC members, Mr. Dharam Singh, to do the honors. Mr. Dharam Singh. Mic test. It's echoing.
So I've written all the 3 points what I think about this day. First, diagnosis is dignity. I think all of you would agree to this, that in accordance with this year's theme, diagnosis, first step to care, I nail this. We can't treat what we don't name it. So over 75% of PWH or CWH are still undiagnosed. And it's not a medical gap, it's a human error. This day is a reminder that awareness saves lives literally. Second, I would say community over isolation. It's this one day a year when a person or a child with hemophilia in Kolkata or a person from Kenya, a doctor or a caregiver wear the same color. And say we see you. Hemophilia can be isolating and this day breaks that. Third, progress with purpose. This day honors Frank Snabel, who turned his own diagnosis into a global movement. And because of him, we went from preparing for the worst to prophylaxis, gene therapy trials, and women's group advocating in same color. This day measures how far we have come and how far we still have to go for treatment for all. Just one more point from the point of view of being a woman is that it means our voices are heard and counted now. For years it was called a boy's disease. Mothers were just called caregivers and carriers were ignored. Our pain was dismissed as normal. Our daughters' bleeding symptoms were overlooked. But today it says women bleed too. The theme, diagnosis first step to care, is exactly what we still fight for, because women are still undiagnosed or carriers who are suffering in silence. And it means that we're not alone anymore.
Thank you so much, ma'am. मैं एक्सपेक्ट कर रहा था कि 2 वर्ड्स या 2-3 लाइंस में आप करेंगे, बट दैट वाज ह्यूज कि आप इतना सब कुछ सोच रहे हो हीमोफीलिया डे के बारे में. एंड वी विल मूव टू द नेक्स्ट सेशन, और उसके बाद भी हम फिर से आपके बीच में होंगे और आपसे फीडबैक लेंगे आपके क्या विचार है आज के दिन के बारे में. सो नाउ आई रिक्वेस्ट डॉक्टर ट्यूलिका सेठ फ्रॉम एम्स न्यू दिल्ली. शी विल बी टॉकिंग ऑन हीमोफीलिया A in need for prophylaxis. Please fix the mic, it's echoing a lot. AV department, थोड़ा सा देखिए please. Mic test. Hello. Hello.
So wonderful to see you all. We are all friends and colleagues, and we meet here every year. And every year there is progress. There are new things that are happening, but it is a journey. So there's still much more that we need to do. Today this is a sponsored session from Roche, where we're talking about people with hemophilia A in need of prophylaxis. These are some of the disclaimers that I have. So in this august audience, everybody knows about hemophilia. We know that many patients have delays in diagnosis, and many times the symptoms are ignored until they become very severe. Underdiagnosis is a huge problem, not only for patients with severe and moderate hemophilia, but also there are many persons with mild hemophilia who are as yet undiagnosed. The majority of our HFI members are severe or moderate hemophilia patients. We know that unfortunately most of our persons with hemophilia have to reduce their physical activity because of the risk of bleeding, and they don't receive prophylaxis. It was beautifully highlighted that women are also bleeders, and we have done a study at AIMS also where we looked at hemophilia carrier mothers
and we found that many of these mothers also had low factor levels, and many of them had had serious bleeding episodes which had unfortunately been overlooked. So we must make sure that we are looking after all of our women carriers as well as those women who have other bleeding disorders. Persons with hemophilia A experience many challenges. There are also many psychosocial issues. Dr. Hemant, who is also a person with hemophilia at AIMS, has done a study because he is a doctor who is doing MD in psychiatry. He's published a paper on the psychosocial issues faced by the persons with hemophilia. And persons who have mild or moderate hemophilia sometimes lack support. So just to remind all of you, in the disability guidelines that we have framed, anybody who has less than 5% factor who is a moderate hemophilia will also be entitled to the disability certificate. And persons with hemophilia also have many other issues as well as, unfortunately, poor quality of life due to the bleeding. So the severity of bleeding we know is very important, and persons with severe phenotype definitely have the most serious problems, but we also know that some persons with moderate hemophilia and a few even with mild hemophilia can have problems. So it's important to simply not look at it in one dimension. We need to look at it in the complete dimension. So the factor 8 activity is very important, but so are the genotype, because we know that many mutations are present. There are X chromosome inactivation in females. There's also the factor 8 pharmacokinetics that happen in persons. For example, all of us know that children metabolize the factor 8 much faster than adults. Some persons who may have a different BMI and blood group and von Willebrand antigen binding and clearance may also have an effect, as well as persons' activity and joint status. So there are persons who may need more activity either because of their interest or because it may be required. We have persons who live in rural, remote areas or other areas where they are forced to have more activity. So all of those things also impact. There are now that we're understanding the coagulation system, we are also understanding that a person's AT3 levels, protein C, S levels and other things can also impact on whether they are having a higher bleeding point or a lower bleeding point, as well as the inhibitors of coagulation, and many of these factors are being looked at in the new rebalancing agents which are coming for treatment. So there are many challenges and they vary between person to person, from state to state and wherever they live. So diagnosis is still a big issue in our country, and we have made some advances in the care, but still much more has to be done, and it is unfortunately not uniform all over the country. The multidisciplinary care team and the HTCs that were so beautifully highlighted by Dr. Joseph are available in many parts of the country, but there are other parts where they're still lacking, and that limits the access of the patient to the HTC care. There are healthcare provider shortages. We need many more specialists in this field, and NHU, as you know, every year the IHAD organization is aiming to try to address this, and all of you are also helping so much to address this through the various activities done by HFI and the projects. The novel therapies are definitely going to be a game changer, I feel, in our country, because they can be given less frequently, they require less monitoring. Persons with inhibitors or not inhibitors, they do really well. Regular prophylaxis is required, whether we do it with clotting factors or we do it with non-factors, but really prophylaxis is the need of the hour. And some of the states have done a wonderful job in putting patients of both pediatric and adult patients with inhibitors or those with target joints on prophylaxis. Everything is related to cost, but I think nothing is as important as health, and that is the most important thing. Sometimes poor adherence is an issue, but I personally feel that if patients have access, they will always take the treatment. Many times the adherence problem is not because of the patient, but because the availability of the drugs may not be consistently there. So that's really important, because if we don't have good adherence, then we're not going to achieve our aims. The long term aim is to have a functional cure where patients can live a very normal kind of life, where they can do all their activities, and we can avoid the joint destruction and the joint replacement surgeries that is there. So health equity is a very important thing that we must look at. There are going to be some patients who will benefit with some basic treatment. There will be some patients who might need more advanced treatment to manage their joint health and to manage their frequent bleeds. So we are not always looking at equality. Everybody should get what they need depending on their disease phenotype. So we need to have a more individualized approach. Patients must remember physiotherapy is highly important. Most of my patients, they keep asking for factor, but when I ask them about their physiotherapy, they're like, yeah, I do that at home. So no, we must continue to give physiotherapy as much importance as the factor, because in hand, if we do both of these things, the care is going to be so much better. So we are now understanding that there are some patients who were maybe not in the severe category who also may benefit from prophylaxis. So there's a lot of things that we must look at. As I said, in our disability guidelines that came out in the Gazette of India March 2024, we have actually put anybody with a factor level less than 5 can be given a disability certificate, and this was because many patients who are moderate hemophilia also have a severe phenotype of bleeding, and sometimes the factor level in some of the smaller centers, they may actually give 1%, 2% when it's actually less than 1%. So this is very important. And also we want to be able to give patients not just the typical more than 1% trough level that we used to keep for the prophylaxis, but we want to keep as much as a trough level that is required for that patient to prevent them from having bleeds. So there's as I said, there's a paradigm shift. We want to definitely make the diagnosis, but there are patients who may not be severe but may have a severe phenotype, so it's important to individualize. So the risk for bleeding, the presence of comorbidities, early signs of joint degeneration, all of these things are important. We have started a new clinic. In fact, we're doing a thesis also for older patients with hemophilia, because many of them may have cardiac risk factors. Some patients may require antiplatelet medicines. So we want to understand how to manage our patients who are getting older with all of these issues and prevent the risk of bleeding. So what we actually are aiming for is equity. When we have equality, we mean that we have something for everyone, but that may not be enough for some patients. So there may be some patients who may need less, some patients will need more, and this may also vary within the same patient at different time points. So we want to be able to have everyone reach a good level of care, and that level of care should be the same. So rather than looking at equality, we want equity, and equity is very important because that way we can make sure that the patient gets everything that they need, and we can look at clinical trials to help bridge this equity gap. We also want to look at women, and we definitely want to look at the clinical phenotype of the patient so that they get what they need. Prophylaxis, we all have read the WFH guidelines. We know that it is important. We know that joint health will only happen if we give prophylaxis, that is, we can prevent bleeds. And this is standard guidelines, everybody knows this. The problem is that unfortunately we are not always following it, and because of that many of our patients have joint damage, and this poor joint health leads on to further future problems, and there's also a risk of intracranial hemorrhage. So it's really important that whenever we start prophylaxis, we start it as early as possible, and some of the states are doing a fantastic job by approving prophylaxis in all pediatric patients. And once that prophylaxis is done at a young age, these persons will have very good joint health for the rest of their lives. So earlier we only thought of prophylaxis in severe patients. Now we're thinking about it in moderate patients. Maybe mild patients it may not be so required, but definitely the moderate is coming in, and there's plenty of studies to show that when we are doing prophylaxis, the joint bleeds and the ABR reduce significantly. This is a study from the US where they looked at patients on prophylaxis and those who were only receiving on demand. And you can see that when these patients were followed up by MRI and X-ray, they had much better measures. So there is no doubt that wherever possible, we must go for prophylaxis. With on demand, there will still be many episodes of bleeding in the year. So just to summarize, prophylaxis is the standard of care, provides long-term reduction of bleeds, improves the functional limitations and prevents disability, can prevent the need for orthopedic surgery, and we're all already seeing a huge impact. About 15 years ago, we used to get patients who used to come to AIIMS New Delhi for 4 joint replacement surgery, both knees, both hips. But now we're seeing very few of those patients. Yes, we still have patients who come for joint replacement, but not the 4 joint replacements. But we still need to do better, and we can avoid hospitalization. So this is just a highlight summary of this. We need to make sure from our side, from the administrators and the doctors, that we have uninterrupted availability of the product. We need to have patients learn to do self-infusions, though many of the non-factor products are subcutaneous, so that makes it much easier. We need a multidisciplinary team. We need to have patients who understand, and we need to also understand the patient's motivations and their ambitions. And there will be patients who will need different dosing because some are more bleeders than others. And this is an investment. It is not a burden, and I think we all must join hands, as we have been doing, to take this forward. Thank you so much.
Thank you so much, Dr. Tulika ma'am, for this awesome session. और यहाँ पे बहुत सारे लोगों ने relate किया होगा how the life is getting changed after these new age treatments. So myself will felicitate Dr. Tulika ma'am. So every successful program has sponsors, and their contribution for the program is equally needed. So from the Roche, we have a team of representatives, Mr. Gaurav Jain, Dr. Jaswinder Singh, and Kareen Naran. So I request all the gentlemen to be on stage. Mr. KVS Prasad will be felicitating all the dignitaries. Our next session is panel discussion chaired by Dr. Joseph Johnson, CMC Ludhiana. Panelists are Dr. Rupreet Pasai from NHM Nagaland, Dr. Suresh Mohankal, NHM Maharashtra, Dr. Suryansh Oza, NHM Uttar Pradesh, Dr. Mohammad Ziaul Haq Ansari, dentist. He himself is a person with hemophilia. Mr. Jigar Kotecha, Secretary of Hemophilia Society Mumbai chapter. He's also a hemophilic. I request everyone to join on the stage and let's start the discussion. They will be talking about multiple things, and one of those is multidisciplinary comprehensive hemophilia care.
Good morning, everyone. So we have people from different sections. We have a dentist, we have an HFI secretary, we have medical doctors and nodal officers here. Just to get the names familiar, sir. So we have Mr. Jigar from secretary from Mumbai chapter, Mumbai, and Dr. Mohammad
Ziaul Haq.
Dr. Ziaul Haq. Ziaul Haq is a dentist, right?
Yeah.
I'm sorry. You're from which place, sir?
Jabalpur, Madhya Pradesh.
Jabalpur, Madhya Pradesh. So we have, and Dr. Suhas is from Maharashtra.
Yeah, that is Dr. Suhas Monarkar. It is Maharashtra, Mumbai, NHM. Yeah.
Okay, sir.
Dr. Suryanshu from UP.
Suryanshu from UP. So Dr. Rupert is not here from Nagaland, right? Ah. Okay, sir, please come. So we have representation from the east, west, central zones now, from various sections, and it's great to have all of you here. I don't have any slides or presentations and pre-made questions. It is just to elicit some discussions, and I'll be happy from the audience also if you have some questions to ask. The topic of discussion today is multidisciplinary comprehensive care. In the sense, imagine you are an HTC and you have to render the care, and what is your expectations and where do we go? I'll start with Dr. Jigar. What are your expectations from a medical multidisciplinary team, from the HFI secretary point of view? If you were to send a patient to a center, what are your expectations?
Okay, so in India, KM Hospital was the first hospital who started the multidisciplinary care. Okay, all the doctors, hematologists, occupational therapists, orthopedic surgeons, general surgeons, they sit in one platform. Patients will come and they will discuss their problem, and then solution will be given at the same platform. So that thing we want to be everywhere. Now KM Hospital is a tertiary center, but this should be implemented in all the state levels civil hospitals as well. And along with multidisciplinary care, we expect all type of factors to be available. Because care itself starts from factor. So from plasma derived to non-factors, we need each and every product to treat hemophilia.
Sure. So you, in other words, you are saying that you would like to have the same level of care which you got in KEM hospital with all the multidisciplinary specialties across. So I want to hear from Dr. Rupert, how much of these expectations are being met in your state?
Sir, to be very frank, ours is a very small state where many things are in the nascent, but I would like to copycat whatever was said in the previous presentation, that we will expect that services are, affordable, accessible, and equitable.
So the reality is that it's not being met as of now, but it is a process.
Yes, sir.
Yes,
sir. Definitely.
So Dr. Suryanshu, is it being delivered in your care, and you are able to, what would be the gap in your situation?
As far as UP is concerned, we have 26 hemophilia treatment centers and 5 major hospitals which runs this program. Basically, SGPGI is our guide for the whole program, and they are equipped with all needed required diagnostic tests and as well as factors. They are providing factors, they are purchasing factors, and they are distributing factors to each hemophilia treatment centers. In fact, if you will say for UP is spending 80 crores of budget on hemophilia for factors only. We are providing, NHM is providing 50 crores, and government of UP has provisioned of 38 crores on its own. Still, we are lacking to cater prophylaxis, since we have 4,000 patients, and in fact, I am going for next PIP presentation. But I could not find ki how to calculate requirement of a patient for annual expenditure. एक घटना मैं आपको बताऊं, अभी 4-5-10 दिन पहले someone from Pfizer came to me and he asked कि हम एक नया कोई product ला रहे हैं और I am here for a courtesy meeting. I just asked him how much is the cost of your product. Earlier he was not very responsive और वो थोड़ा सा हिचकिचा रहे थे उसका रेट बताने में. तो then I asked, नहीं, I am serious because if I have to put it in proposals, PIP proposals, then I must know the cost of the. Then he said 35 lakhs to 60 lakhs for a patient annual expenditure. I said, what is your income? मेरे तुरंत ही मेरे दिमाग में आया, मैंने कहा कि भाई आप ऐसे किसी आदमी से नहीं पूछना चाहिए कि आपकी सैलरी क्या है, but I just asked what is your income. तो थोड़ा सा वो hesitant हुए and ultimately he said around 60 to 65 lakhs. तो मैंने कहा even in your case you cannot afford this medicine if 1 or 2 patients are there in your family. How can you expect that a general common Indian citizen can afford this treatment? In fact, the सबसे बड़ा drawback is the कि we are totally dependent on government just because it's very costly all. Still UP is providing a lot and taking care of lots of patients, but gaps are always there. We are committed to
Sure. So we heard a government perspective from there. You talked about the funding, and I am assuming that the funding is increasing every year. Now it has reached 80 crores, probably one of the highest funding per state. The other states, some of them are 100, 150.
Even then we are not given prophylaxis to every patient. Just not only because budget constraint is there, because factors are not readily available in market, and the firms are not coming. They are coming on their own rates.
Correct. So that's the problem. So that's something which we need to discuss, and I'm sure the nodal officers and the decision makers can say. Do you want to comment anything on this, Dr. Suhans, from the Maharashtra point of view?
Yes, sir. Sure. First of all, it's a lengthy explanation of mine, but I'll go very slowly. First of all, in Maharashtra, there are 35 HTCs. All hemophilia treatment centers are now converted into a hemoglobinopathy centers as per rules and regulations by GOI. Our first approach is that it should, as rightly said by Jigar and sir, it should be a multidisciplinary, what you call an approach. So all HTCs are nearly committed to a district hospital. The district hospital out there is completely supporting them in surgeries, in orthosurgeons, in even the UDID, what is known as certifications, that is the disability certificate. Our center of excellence, or what you call competence, is AIIMS Nagpur. Now all this starts with multi-level tasking. The first approach of mine when I took the chair was training. It starts with basic training or getting an impact on the proper treatment person at the site where the HTC is established. So I definitely thank Roche team who themselves made an effort that it happened in Nagpur with the what you call known as help of AIIMS Nagpur, that we conducted a 2 days training workshop. It touched sickle cell, thalassemias and hemophilias. Maximum doctors from all HTCs along with the nurses and the pharmacists were there. It was properly guided by 2 of the main speakers like Dr. Bafna and Dr. Upase. Today in my team, myself, I am along with Dr. Hitesh Pagare, Dr. Samiksha and Dr. Manohar Bansode. These young team is again enforcing that we are readily coming up. Now second tasking is making the availability of drugs, or what you call the anti-hemophilic factors and non-anti-hemophilic factors also, what is known there. So we have started first demanding budget, what is there in the PIP through NHM, through state budget. Thirdly, we have activated what is known as the MJPJY or the PMJY. I think so you all maximally are aware of it. We are having nearly 35 packages in it, and every center is asked for the patients to be enrolled in it. every package is directly put into the bank accounts of the district hospital itself, and you can't
Audibility nahi hai. You can't hear?
हेलो, भाषा समझ में, हिंदी में बात करूं?
हाँ, करो
चलेगा, अब मैं कोशिश करूंगा. थैंक यू सर. तो हमारा जो सेकेंड लेवल ये है एक्टिविटी इज एक्टिवेशन ऑफ MJPJY या PMJY. इसमें हमारे पास 35 पैकेजेस है. दोज आर ऑल डिजाइंड एंड टेलर्ड. इट इंक्लूड्स टोटल एंटी हीमोफिलिक ड्रग एक्टिविटी का ट्रीटमेंट. इट ऑल्सो इंक्लूड्स NHL नॉन हीमोफिलिक फैक्टर्स, उसका भी ट्रीटमेंट. इसमें इसके पैकेजेस रनिंग फ्रॉम नियरली 35,000 66,000 वहाँ तक है. This is well designed, and as you take one medicine or two, it doesn't matter, the whole package has been given to the district hospital so that this activity goes on regularly. This is the second part of activation. Third part is ESICs. ESICs are regularly purchasing anti-hemophilic factors and what is called non-hemophilic factors on the ESIC RCs. Fourthly, what maximum, only one person I will definitely take the name, never had taken a name before, is Jigar Koteja. He himself has seen that availability of funds first and then the medicine is taking place at medical colleges. It wasn't there till date. NHM was supporting initially, but due to some GOI restrictions, we had to curtail it out. But full efforts I say from Jigar Koteja ji. Now tertiary care centers like KEM, Sion have come up with what is called a funding stage, where in case of such what you call critically ill patients, they are being giving treatment at that particular places, these tertiary hospitals. And I'll rather feel nice that Jigar may please elaborate over it after my talk is over. So this is 4 level of tasking which we are currently on. This not only implicates only to hemophilia but other diseases also, but I will cover hemophilia. Now fourth, what after this what you call level of tasking, fifth, what we are implementing is that the exact valuation of what is known as the inhibitor study, where we are trying to incorporate any of the person in some activity, those who are going to do the inhibitor testings for the patients. It is have two parts. First, exact data coverage, availability and non-availability of medicines for the inhibitor patients, and prophylaxis on both sides, in sense of non-hemophilic factors, what you call, and hemophilic factors, which are the best in the market.
So can I just pause you for a minute, and similar to what the UP government has done, what is the total funding availability in Maharashtra? 80 crores there. What is yours?
Sure. Currently, our demand that had gone to PIP, now we are in the pre-NPCC section, is around 147 crores.
147.
Yeah.
Okay, great. So just to ask you, because you're working, so it looks like your HFI, the center, and your HFI, the state center, and you are working very closely. And do you have a mechanism of the referral pathways from the district hospitals to the government hospitals as and when needed?
Basically, sir, every patient is taken as mild to severe.
Okay.
The judgmental part is totally at the physician's level. They are what is known as our 108 services. First, stocking or caretaking for the 108 ambulance to reach that places. That is first care that has already been taken or handled by the government itself. Once the patient reaches there, initially in between there was a big gap. This gap was because of non-availability of either the anti-hemophilic factors or the any emergency medicines as such funded. But now, just in rather I'll say within a week, these funds have been allotted.
Okay.
And full, again I'm stressing over it, Jigar did it. Now how the linkages and what he used, it's up to him, but he has worked out now availability of funds for purchasing and monitoring or taking the need of this critically ill patients at KEM or any tertiary hospital or say Sion is been taken care of.
Sure. So the take home for the audience is that a very coordinated working along with the HFI and the nodal officers is the key, and you need to identify steps of care, tasking to be done. The first level, second level, that is some strategy which you have used, and some of you can take that home. So coming to Dr. Zia Hulkak, you are a dentist by profession from Jabalpur. right? And you are a patient yourself. Okay, let's first talk about the professional part and then the personal part. From the professional point of view, which center are you working in? Jabalpur. I mean, it's an HTC or a HTC. In which hospital?
Triveni Hospital.
This is a private or a government hospital?
Private
Hospital. So, do you have a comprehensive care center there?
Yeah. हमारे मतलब हॉस्पिटल में सारे मतलब जितने भी मल्टीडिसिप्लिनरी
Just close by, yeah.
जितने भी मल्टीडिसिप्लिनरी जो भी फैक्ट पॉइंट्स हैं जिसमें न्यूरो से लेके हर चीज़ लैब टेस्टिंग वगैरह हमारे सब चीज़ उपलब्ध है, न्यूरो सर्जन से लेके हर चीज़। वहाँ पर कभी भी पेशेंट को भी कोई भी तकलीफ जैसे होती है तो वो आते हैं तो उनका उस ट्रीटमेंट के हिसाब से मतलब जो उनको नीड है उस हिसाब से उनका ट्रीटमेंट करते हैं। मान लीजिए कोई पेशेंट आ गया या आईसी ब्लीड का भी होता है तो वहाँ पर ऑपरेशन के लिए भी हमारे यहाँ फैक्टर्स के साथ में ट्रीटमेंट सुविधा भी उपलब्ध है वहाँ पर।
ये फैक्टर HFI से के थ्रू आते हैं कि
HFI
के थ्रू आते हैं? सो यू हैव सो अक्यूट ब्लीड, हाँ जी मालूम है कि अक्यूट ब्लीड इमरजेंसी में आ गया, उधर के हिसाब से वो पाथवे हो गया, केयर पाथवे. Second comes the patients who requires planning, for example joint issues, where multidisciplinary team has to say, orthopedician, the physiotherapist, the hematologist, everybody has to sit together and say, do you have a hemophilia clinic possibility there? Hemophilia clinic where everybody comes together rather than the patient goes to multiple places.
No, we still not have, but there is a doctor, orthopedic and other hematologists are there. तो कोई भी जैसे प्रॉब्लम आती है तो हम पहले हेमेटोलॉजिस्ट से भी कंसल्ट करते हैं जो हमारी सोसाइटी से अटैच्ड हैं, फिर उनके पास जो ट्रीटमेंट प्लान होता है तो उसके बाद हम उनका ट्रीटमेंट प्लान करते हैं, फिर उसके अकॉर्डिंग अगर उनको ऑपरेशन की ज़रूरत है तो फैक्टर का अरेंजमेंट करते हैं, फिर उनको ऑपरेशन होता है, फिर पोस्ट ऑपरेटिव भी फैक्टर के रिप्लेसमेंट में उनको ज़रूरत है तो वो सब भी हम प्रोवाइड करवाते हैं पेशेंट को.
ठीक है. सो ठीक है. एनी वन ऑफ यू हैव एक्सपीरियंस ऑफ having everybody coming together, patient is in one place, doctors and everybody else come around? Hemophilia clinic concept anywhere?
Yes, as I mentioned earlier that we have it in KM Hospital luckily, and even after Chandrakala ma'am left KM Hospital, it is still going on, and I have personally taken care of it, that it is never stopped.
Great.
So all the department stakeholders are present and the immediate decisions are taken.
Yeah, so just for the audience, yeah, you can come. You want to talk? Okay. So can somebody give a mic to the audience here, Dr. From Jab, yeah. So basically, can somebody give a mic to the audience here? You can give this mic only. So the point we are trying to say is that there is a lot of efficiency in creating a hemophilia clinic rather than patient going to multiple places and seeing patients along doctors in multiple areas. If you can have a hemophilia clinic where everybody comes, decision making is faster. So your comments.
Sir, I am Dr. Anburajan, a family physician from Tamil Nadu, southernmost part, Tirunelveli chapter. We are running a HTC. So we are talking about a multidisciplinary center, keeping all the specialities in one place and one time taking a decision immediately.
Correct.
As if it comes.
Yes.
So they are blessed and they are having all the facility. But if you see the whole India, the status of whole India, we have to say there are certain states which are not even having a single hematologist. There are all the specialists are not at all available. If you take my center, to see a hematologist, I have to travel 300 kilometers to the north or 200 kilometers to the south. So that is the availability of the specialists, and most of the, PWH, they have to travel a lot to see a specialist care or tertiary care. We have to concentrate on level 1, that is primary level HTs, where one doctor can be trained in multidisciplinary. If a committed doctor is trained in multidisciplinary, he can take care of all the needs, immediate needs.
Yes.
And then a consultant can be called for, or they can get that access by so many other modalities like telemedicine and are all now available. So we are managing a lot of cases, because I had personally training in CMC Vellore on bleeding disorders, and I had a training in the local hospital, our Tirunelveli Medical College Hospital in orthopedics as a senior trainee. So even all the minimum care we can give in the HTC for all type of patients.
Sure.
So developing a multi-speciality, training to a nodal person, that can also be a good model in the primary level care. It's because that primary level care HTCs are more needed in our country, a country like India. That is my humble suggestion, sir.
Absolutely. So that's a very good point you have made, and you cannot get hematologists everywhere else, and you just need an MBBS doctor or an MD physician, pediatrics, or yeah. Go ahead.
Thank you so much, sir, for enlightening this thought over. हेलो या तो हिंदी में ही बात करूँगा. जब हमने ट्रेनिंग नागपुर में लिया सर, दैट वेरी मोमेंट वी हैड n नंबर ऑफ स्पीकर्स, जिसमें 3 या 4 हिमेटोलॉजिस्ट सर्स थे, मैडम्स थे, अलॉन्ग विथ एम्स की जो पूरी टीम थी. व्हाट दे ऑल अग्रीड वाज नेटवर्किंग. They themselves committed. I took a meeting of the hematologists, and I've called maximum hematologists, might be in Pune, if you say one of the districts in Maharashtra. They are willing or accepting to give guidance, training, or being a local consultant for the following districts, but what we lack is a networking thing. So I have already talked, we are in the verge of establishing this network. The hematologists are going to be, rather sirs, madams are going to be one of the expert consultant, free of cost, giving their total services for the cause of the patient and his life to the particular center. As sir rightly said, first line of treatment where a patient comes in is the doctor who is attending at that very place. No consultants nor any specialists are available. But if he knows maximum 90% of the ailment is taken care by himself only.
Sure.
So that is, we are on the verge of it.
So we are agreeing upon the same point, that we can have family physicians, general practitioners who can be trained. Okay.
So
Related to
I'll
you want to add a
one
point.
line.
So we have another 5 minutes, 10 minutes to go. Yeah.
Hemophilia care in India should not depend on which city you are born in. It is your right, and it should not be a luck.
Correct. Good. So it should not be luck, and that can happen by standardization and increasing the awareness and the education. Coming to the moot point again about the role of nurse coordinators or a hemophilia coordinator individual. I'll start from Dr. Rupert on this comments about doctors. Yes, they are important. I'm not saying that, but to me, more important than is that point of contact person or a nurse coordinator or a hemophilia coordinator. Not necessarily the nurse. It could be anybody who is compassionate and has an idea about how to intervene. Dr. Rupert.
In our setup, sir, I just wanted to give you a picture. Yes, we have HR constraints, we have accessibility gaps, and we fall in the category where sir was mentioning. But in spite of all that, the little we could do was we could train a nurse who is there at the station always 24 hours. So they have a roster, so they give care in whatever possible ways they can. Another thing is the factor which we are giving, just wanted to mention about it. We are giving prophylaxis to the little patients we have, 14 patients we have, 13 are hemophilia.
On prophylaxis,
yes.
okay.
On factor 8 and one on factor 9. So we are giving extended half-life, this thing, recombinant factor for all of them on prophylaxis. So one thing which, as someone who is attending an important program like this. Like just a year back, I went back, and ours is a small state where we can also influence the, politicians in the little ways possible. So we have seen in the video that the politician was also quite involved, and then that imicizumab at low dose was propagated. So that way, if given opportunity where budget is not an issue,
Sure.
and then if an honest opinion be asked, so what, as as persons attending important meetings like this, how do we approach the government regarding that? That was some of the issues actually I always had in mind. So as I go back, I will definitely
The
go
tricks of
back
the
with
trade in
yeah,
getting the
expert
advocacy
opinions we
going
should
to the
give.
government.
Yes, yes.
Okay, Dr. Suryanshu,
Thank
what
you.
measures can you take, or others can advise, would you say, about promoting the nurse or a hemophilia coordinator concept in the state level?
In our state, we have one state coordinator, hemophilia state coordinator, who is posted at SCPGI Lucknow, and he supervises all 28.
No, so I'm talking about individual
and
centers.
we have provided one staff nurse, one physiotherapy, and one medical officer.
Okay.
On each hemophilia treatment centers, and approximately 8 centers are equipped with additional coordinator also.
Okay, so within the constraints of the resources which we have, one of the promotions we were trying to do was to have a nurse coordinators training program. How do you think that would be helpful, not helpful? Can you please pass the mic here again? I want to hear from all of you about, so a nurse coordinator or a hemophilia coordinator center wise, HTC level wise, whether we will be able to initiate that process or not. So while the mic comes in, anybody wants to talk about that? While mic is getting ready, yeah.
Hello. Yeah. So initially, sir, 2 minutes, please. So I agree what the main head speaker is talking, and what all is required. The need of the hour is अपने को हर जगह coordinator बोलो या consultant
nurse coordinator or hemophilia coordinator.
Hemophilia coordinator की गरज है. तो हम लोग ने क्या वर्कआउट किया सर महाराष्ट्र में? ऑलरेडी हमारे पास सिकल सेल डिजीज प्रोग्राम रन है. It is nearly in 21 districts. Leftover districts are also there. So considering this part, the sickle cell coordinator is now converted to hemoglobinopathy coordinator. उनका क्या मेन रोल है? Why are we emphasizing? First is pre-marital counseling, which is the must and need of the hour. हम सब टेस्ट करते हैं, HIV करते हैं, ब्लड ग्रुप करते हैं, हर एक का गोत्र सब जो भी है उनके हिसाब से वो चलते हैं, बट वी नेवर डू पॉइंट ऑफ केयर टेस्टिंग. जो मस्ट है वो हिसाब से हम उनको कन्वे कर रहे हैं. जब ये ट्रेनिंग नागपुर में हुआ था, दैट टाइम ऑल्सो विद द हेल्प ऑफ द कंसल्टेंट्स वी टुक ऑल, इनको बताया गया कि व्हाट इज द नीड ऑफ द आर. तो कंसल्टेंट्स, जैसे सर अपन बोल रहे कंसल्टेंट्स नहीं आ रहे मेरे मुंह में कंटिन्यूसली, बट आई विल से द कोऑर्डिनेटर्स, इनका नीड है. इट इज द नीड कंपल्सरीली. दीज आर द मेन linkages between the doctor, nurse and the patient. He understands, he is in the depth of the patient, and also giving maximum part is known as counseling.
Sure. So because want of time I need to wind up now. Yes sir.
Yes. Hello, I am Dr. Manohar from Maharashtra team. In Maharashtra there is very good work on hemoglobinopathies. Sickle cell anemia and thalassemia is also running already in good manner. This hemophilia is also conducting, and now we are burdening on only families and state and NHM. But rather than this budget problems, all are saying budget problem. But I am saying there is no budget problem, because in Maharashtra there is one good practice, MJPJY, Pradhan Mantri Yojana bhi hai. So many packages are in MJPJY, Mahatma Jyotirao Phule Yojana Antargat. From 2002, 50,000 in one sitting, there is one package. there are all hemoglobinopathies, including hemophilia also. Therefore, don't say there is no budget. Budget we should create now. How empanel the all institutes, hospitals, or any authorities, and create the budgets. Budgets are created. These are not pulled from any others. These are so many sources, but MJPJY is the good source for this. I am practicing in Central Hospital Ulasnagar with good MJPJY practices. Therefore, don't say budget, no budget, no budget. Because hemophilia is the family problem with not only the detected hemophilia, but his family also included in this. Please, all institutes, empanel MJPJY or other so many schemes are there in Maharashtra and also in other states also. So
Thank you, sir,
please,
for bringing up the budget
thank you.
issue. And sir, last comment, and then we'll wind up this. Ma'am also wants to say something. Okay. After this, you. Okay.
So, regarding the
Coordinator.
matter on discussion, regarding the nursing coordinator, I have to say it is a very good strength that CMC Vellore is conducting nurses training program every year for hemophilia care. And also they are giving lab technician program also. And they also give physiotherapist training also. So the three
main
trainings are very cardinal one. And apart from that, whenever possible, they give training to doctors also.
Yes.
And even specialists. So every time when they conduct the program, we from our HTC, I'm sending two nurses or two lab technicians, one physiotherapist and one doctor regularly. Now see, the goodness is the nursing coordinator. I'm here in Delhi. There are 3 post-operative patients in the hospital, hemophilics, intracranial bleed, post-tumor surgery and fracture surgery. So they are being cared by the nursing coordinators trained in hemophilia. From
Absolutely.
distance I can able to operate. Even the diagnosis, even calling the specialist in
Absolutely.
time, everything they were able to do it. Nearly 10 hemophilic will come every day. One nurse in the nursing coordinator in the daytime, one nursing coordinator in the night duty. They are able to take care of the hemophilics. So
Sure.
this is a very good training we are getting from CMC
See,
Vellore.
Vellore,
We are
and that
very
is
much
something
thankful.
which you can promote. Okay, madam. Yes.
Good morning to all. I am Dr. Meena, pathologist and medical officer in charge of the laboratory attached to the Hemophilia Treatment Center, Aluva, situated in Kerala state. Okay, as for hemophilia, we have a comprehensive hemophilia care unit there, headed by Dr. Vijay Kumar, and we have a nursing coordinator who is the custodian of all the medicines, and we procure medicines through KMCL funded by NHM as well as the district panchayat. As of now, we have more than 80 patients receiving emicizumab and many patients receiving prophylaxis therapy. And we have a full-fledged laboratory doing all the PT, APTT, factor assays, inhibitor assays, and also von Willebrand antigen and activity tests. And now we are looking forward to procuring chromogenic assay reagents, that is bovine thrombin, and we have applied for the same to the NHM, Ashadhara, who we are sure will take care of the our demand. And for the nursing coordinator, we have a very good nursing coordinator who is well trained from CMC Vellore, and also the physiotherapists are also trained from CMC Vellore, and now we are catering to a population of more than 1,000 hemophilia patients in our hemophilia treatment center. And also we conduct hemophilia clinics, and the services of hematologists Dr. Neeraj and Dr. Rema from AIMS are rendering their services selflessly every week. And 2 weeks we take care of the thalassemia and other hemoglobinopathy patients, and for the other 2 weeks we keep apart for the hemophilia patients. And proud to be part of this hemophilia treatment center in Alua. And also this hemophilia clinic is attended by Dr. Shiji, who is a physiatrist from Lisi Hospital, which is also another private hospital in Kochi. And with all the services, we are going ahead with the painless, pain-free hemophilia patients. And we are, and our physiotherapy center is also headed by eminent physiotherapists.
Yeah, thank you, ma'am, for sharing that. And so we have heard a heterogeneous way of one more point.
One point.
Okay. Okay.
Good afternoon to all the august audience. I am Dr. Anju from Nagpur, and as you were just talking about the nurse coordinator, since I am from the HTC, which is from HFI, I just want to highlight one thing, that the nurse coordinator or any hemophilia coordinator, whatever educational qualification you want to keep them as, so it is a very wonderful idea to train them. And I would like to really, it is a welcome idea to have a standardized program for them and give them 1, 2, 3, 4, 5 what they're supposed to do, with their roles being properly designated and designed, so that they don't, they have a clear-cut indication as to what they are supposed to do. That would be very, very helpful to people like us who are working, and that can really bridge the gap between the trust hospital HTCs with the government HTCs. So that's what I really wanted to request you for. Thank you.
Yeah, thank you for that support. So I need to wind up, sir. Now we are already over short time. So thank you so much for that active interaction. We have had, just to summarize on what we heard from everybody, networking is important. Budget is not at all a problem. Work together with the nodal centers and the HTCs, and a family physician can be trained, or any physician can be trained to be a physician required. And I think with a nurse coordinator or a hemophilia coordinator, because nurses' attrition is very high these days, they're all going abroad, so you may want to have some other healthcare professional who can take this job. And we are in the process through IHAD to have a structured training course online, if we can do that. And thank you so much from all the states, nodal officers, doctors, patients themselves, and Nagaland. We have representation from across. We've seen that heterogeneous care which is there, and of course an opportunity for you to learn from Kerala or from Maharashtra and take the cue to the politicians on advocacy. Thank you so much.
I request all to stay, please. Thank you so much everyone for this very informative session. आप सभी ने अपने जो life experiences और आपके work experiences बताए, it will help everyone to develop their own strategies. Now I request Dr. Joseph John sir to felicitate our panelists, starting with Mr. Jigar Kotecha. Yeah. Next, Dr. Suhas Mohanalkar. It's very proud moment for me because he's from Maharashtra, I'm from Maharashtra. Next is Dr. Mohammad Ziaul Haq Ansari. Next is Dr. Suryanshu Oza, NHM Officer, Uttar Pradesh. And Dr. Rupert Pesai, NHM, Nagaland. Thank you so much, sir. Before diving into the next session, let's recharge ourselves with tea and coffee. This is a short washroom break as well. So within next 15 minutes, हम वापस यहाँ पे आएंगे. Because next sessions are very exciting. अभी 12:05 हो रहा है. 12 12:20 12:20 को we will be back in the same hall and we will start the sessions. Thank you. और लगेज नीचे लेके आएंगे. Again, I'm requesting all the participants to do the checkout. Checkout time already over हो चुका है. हमें फटाफट उनको रूम कीज हैंड ओवर करनी है. बट थोड़ा जल्दी करके आना है. हमारा प्रोग्राम हम शुरू कर रहे हैं. Samar sir, please settle down. Dr. Parul ma'am, are we ready? Ready? हाँ. Okay, perfect ma'am. ठीक है. So our next session is challenges with existing therapies and need for newer therapies. So that will be led by Dr. Tulika Seth and Dr. Parul Bhatt. Operator, please change the screen. So the host of this session is going to be Dr. Amod Tilak from Pfizer. And our panelists are Dr. Tulika Seth and Dr. Parul Bhatt.
Thank you, Saurabh. Good afternoon, everyone. I am Dr. Amod Tilak, representing the medical team working for hemophilia with Pfizer India. And it gives me immense pleasure to be here with you, joined by two experts, Dr. Tulika and Dr. Parul, for the subsequent panel discussion. Some time ago, Saurabh asked the question to the audience, what does World Hemophilia Day mean to you? And I was trying to put my own thoughts together with respect to what do I say if I get asked such a question. And it just means that we get an opportunity to celebrate all the successes, all the progress that we as India have made when it comes to hemophilia management. And I would like to thank HFI, Mr. Premroop and his team for giving me this opportunity to learn more from all the experts and the experiences when it comes to hemophilia care, apart from all the theoretical knowledge that I have gone through. With that, I'd like to introduce our panel for today. Dr. Tulika Seth, ma'am has already spoken here. She's the professor, Department of Hematology, AIIMS, New Delhi. And we joined also by Dr. Parul Bhatt, who's a professor and head, Department of Medicine, GMS, Sula. We're not going to go through any data. We're not going to talk about any particular molecule, any particular treatment paradigms. It will be just a dialogue between the two experts, Dr. Tulika and Dr. Parul. With that, we bring the first question. So, as I mentioned earlier, over the years, we have seen a significant advancement in the therapies for hemophilia A and B, with patient advocacy groups, HFI being the best example for it. NHM, we heard in the previous panel discussion, the role of NHM when it comes to these advanced therapies. Various states and all our treating physicians have adopted these therapies in different life cycle for each of the states. With that, the question to Dr. Tulika, how do you see the evolution of care for hemophilia in India, and what is the immediate next step or success that you are look at?
So last year I was asked to write an article for the Indian Journal of for the Indian Pediatrics. It's a journal which is for pediatricians in our country, and it was on 50 years of hemophilia care in India. And we can see a huge change From about 50 years ago, people were only getting FFP and cryoprecipitate. There were a lot of problems. There was a very little understanding about what is hemophilia, how does it happen. Prenatal testing was not available, and that's why there was a lot of fear amongst the families about girls who were carriers. Now we are in a much better situation. Prenatal testing, there are Ayushman Bharat packages, so if people are not aware, they must look at it in their own states. The main Ayushman Bharat has packages for prenatal testing. It is about 15,000 rupees for prenatal testing. Of course, it varies depending on tier 1, tier 2, tier 3 cities. So testing can be done for carrier families where they can then make sure that they can have a child that they were prepared to have. The other thing is that now we have many products. We have an ample amount of factor. I remember when factor used to be so difficult to obtain. We also have extended half-life factor, and now we have the new novel agents, the non-factor therapies, the rebalancing agents, the monoclonal antibodies, and this is really dramatically going to change. Earlier, there was also very little understanding about inhibitors. In fact, I still remember when we started prophylaxis about 15 years ago, there was a lot of anxiety amongst the families because they thought that because of prophylaxis, they would get inhibitors. Then we had to convince them that no, having prophylaxis actually protects you from inhibitors. So there were a lot of myths and misconceptions that had to be overcome. Things are definitely better than they were before, but at the moment we still need to make more and more efforts. There are still patients who are not getting therapies that they need. Particularly inhibitor patients still have a problem. Persons in certain states and regions are not getting the products that they need. So things have improved, and with your organizations and the pharma companies and everybody working together, I think we've really been able to achieve what we have. But I'm really looking forward to the next 50 years. I think that's going to be extremely transformative.
I just wanted to add one thing is that there is a real evolution. First of all, I would like to say on this 17th April, happy Hemophilia Day to all. Wishing you all very happy, healthy and very long life, uneventful, number one. And second is for this organizing committee to having me here. And all pharma companies, they are really bring the revolution, of making it available for India. Even though they are a very recognized international companies, they sometimes may be denied to come into India or something like the pricing. But we are really fortunate. We are having a multiple options to treat our patient. And most important revolution is now we are going to get and we are getting a subcutaneous injection. That is one of the fear of taking to the patient for lifetime. Number one, and again there are chances to give at home therapy also will again another change that will bring very soon to our patient. They are not will able to take from the at home therapy. And most important revolution I can say, because of the availability of this product, this is so precise, will have a opportunity or something like a uneventful surgery will be possible. So that is what I found. It is a really promising result and evolution that even the surgery become a new normal, or it will be possible like as normal as other patients.
Thank you, Dr. Parul, Dr. Tulika, for those encouraging words. I'm sure everyone here is looking forward to the next 50 years as well, Dr. Tulika, as you mentioned. Moving on to or going back slightly, so we spoke about the evolution of therapy, but all therapies, be it for hemophilia or any other disease that we talk about, do come with unmet needs, challenges. And these challenges exist across the patient journey, right from identifying or diagnosing a patient with a particular disorder, the patient going on to therapy, maintaining a stable quality of life. So with respect to hemophilia, Dr. Parul, a question to you. What would you highlight as the top 3 critical challenges or unmet needs with the existing therapies that, if addressed, would significantly go a long way in improving the quality of life of the patients?
Very nice question. That is always we are worried about the unmet need. That is what is exactly Okay. So unmet need is always a question. That is always somewhere it is available free of cost or easily available. Consistency may not be there for availability. So there are so many things we have also experienced yesterday's talk, that there is unequal availability in various states or something like various places. So the diagnostic still we have to reach very high. So diagnosis is still lacking. As per the WFH guideline, the expected our patients should be more than 5 to 6 lakhs in India, but still we have able to diagnose only 1.25 lakhs patients in the hemophilia. So still undiagnosed patients are moving around. There are mild cases which are not been addressed. So we have to improvise the diagnostic facility. Number one, prenatal diagnosis we are talking about, but we have to really bring in the practice that, and we should spread the awareness. And of course, we should give the optimum treatment which is available across the globe to our patient. We should try our best that all the products which are available across the globe should be available at our center or our place. So this is what we have to still run very fast. And most important, still we are I have conversation with so many of the person with living with the hemophilia. They are not getting prophylaxis. So that is another challenge for us to cross. Yesterday also I emphasized only and only prophylaxis is a plan for the treatment. There are no on-demand categories there. However, you can categorize mild, moderate and severe, but there are another criteria, only not the factor level. There are 3 criteria to decide the patient is on prophylaxis or not. Let me just emphasize on this, because not only the factor level that tells you that patient is having mild hemophilia, but those who are having mild hemophilia with severe phenotypes and those are having bleeding. So number of spontaneous bleeding is one of the criteria rather than the factor SA level only. And third is the chances of traumatic bleeds. So these are the 3 criteria. Then all the patients should be on the prophylaxis even though they are having a factor level in the body. So these all are the still unmet needs. We have to work very hard to provide the maximum, optimum and reliable treatment to all our patients.
Thank you, ma'am. Dr. Tulika?
Yeah, I just wanted to make a comment on diagnosis. So diagnosis is still something that is a big issue because you... So what I would recommend is that तो डायग्नोसिस एक बहुत बड़ी समस्या है. अगर आप डायग्नोसिस ही नहीं बनाएंगे तो आप पेशेंट को केयर में ला नहीं सकते हैं. डायग्नोसिस थोड़ा सा प्रॉब्लमैटिक है बिकॉज अनफॉर्चुनेटली आप ब्लड सैंपल कहीं और भेज के नहीं करा सकते हैं. जो ब्लड सैंपल है आपको वहीं पे जहाँ पे लैब है वहीं पे लेना चाहिए, क्योंकि ये एक से 3 घंटे के अंदर जो सैंपल है उसको आपको प्रोसेस करना होगा. अगर आप प्रोसेस नहीं करेंगे तो गलत रिपोर्ट्स आएगी. सो इसलिए आपके शहर में आपके पास कोई डॉक्टर होने चाहिए जिन और मशीन्स होनी चाहिए और रिएजेंट्स होने चाहिए. कभी कभी रिएजेंट्स की कमी होती है किसी स्टेट गवर्नमेंट हॉस्पिटल में. तो बहुत सारी प्रॉब्लम्स हैं, बट एक थोड़ा सा सरकार की तरफ से उन्होंने समाधान भी एक ऑप्शन दिया है, क्योंकि अब ये हीमोफीलिया डिटेक्शन के किट्स आए हैं. ऑब्वियसली परफेक्ट नहीं है, जो आपके अच्छे हीमेटोलॉजी लैब और कोएगुलोमीटर उसको तो रिप्लेस नहीं करते, बट जहाँ पे आपके पास बिल्कुल सुविधा नहीं है, हीमोफीलिया ए एंड वॉन विलेब्रैंड के किट्स हैं. ये 200-300 रुपए के किट्स हैं एंड उसमें आप पेशेंट का डायग्नोसिस कर सकते हो. छोटी जगह में भी, रिमोट एरिया में भी हो सकता है, कोई पहाड़ी इलाका है या कोई एकदम जंगल के अंदर है, तो जहाँ पे और कुछ नहीं है आप ये हीमोफीलिया के किट्स यूज़ करते हैं. ये आजकल जेम पोर्टल पे अवेलेबल हैं, ICMR ने बनाए हैं. उसमें डॉक्टर श्रीमती शेट्टी, डॉक्टर बिपिन कुलकर्णी और डॉक्टर रुचा पाटिल का टीम ने ये बनाया है. तो प्लीज़ आप लोग उसको भी यूज़ करिए जहाँ पे और कोई सुविधा नहीं है. बाकी हर जगह मैं कहूँगी कि हर एक हॉस्पिटल में एक कोएगुलेशन लैब होना चाहिए. डॉक्टर जस्मीना मैम है यहाँ पे एंड वो आपको बताएंगी कि एक हीमोफीलिया के लिए तो ज़रूरी होता है, ब्लीडिंग डिसऑर्डर्स के लिए ज़रूरी है, बट जो भी आपके हॉस्पिटल में क्रिटिकली सिक पेशेंट्स होते हैं, जो लिवर वाले डिजीज़ के पेशेंट्स होते हैं या एक्सीडेंट के पेशेंट्स होते हैं, या जो लेडीज़ होती है जिनको पोस्टपार्टम हेमरेज है, बहुत सारे पेशेंट्स में हमें कोएगुलेशन का लैब की ज़रूरत होती है. तो हर एक अच्छे हॉस्पिटल में एक कोएगुलेशन का लैब होना ज़रूरी है.
Thank you, ma'am. मूविंग ऑन टू द नेक्स्ट क्वेश्चन, नाउ हीमोफीलिया की ट्रीटमेंट की बात करें तो पेशेंट को ऑन डिमांड ट्रीटमेंट लगेगा या जैसे डॉक्टर पारुल ने, डॉक्टर तुलिका ने बताया, पेशेंट प्रोफिलैक्सिस पे जाएगा, बट इसकी वजह से पेशेंट में मिस आउट ऑन स्कूल, काम पे ना जा पाए, या ट्रीटमेंट शेड्यूल मैनेज करने के लिए जो टाइम इन्वेस्ट करना पड़ता है पेशेंट के लिए, पेशेंट के केयर गिवर के लिए, उसमें काफ़ी सारे चैलेंजेस होते हैं. सो द क्वेश्चन टू द पैनल, हाउ डू वी एड्रेस फॉर दिस? What could be the approach when we are counseling our patients, when we are talking to the caregivers to address this concern?
So इसमें भी हमें थोड़े पेशेंट्स को कैटेगराइज करना होगा. जब हम हमारे पास केवल फैक्टर होता था तो प्रोफाइलैक्सिस तो हमारे हॉस्पिटल में बहुत सारे पेशेंट्स को हम दे रहे हैं, बट प्रोफाइलैक्सिस के साथ भी अगर आप स्टैंडर्ड हाफ लाइफ क्लॉटिंग फैक्टर यूज़ करते हैं तो हफ्ते में 3 बार इंट्रावीनस इंजेक्शन लगाना है, मतलब साल में आपके 150 तो इंजेक्शंस आपके प्रोफाइलैक्सिस के ही हुए. एंड इसमें भी ब्लीडिंग ज़ीरो नहीं होता था, एंड इसके वजह से आपको एक्स्ट्रा इंजेक्शंस लेने होते थे जब कोई ब्रेक थ्रू ब्लीड है. तो 150 इंजेक्शन प्रोफाइलैक्सिस प्लस जितने भी आपके ब्लीडिंग एपिसोड्स होंगे उसके लिए आपको देना होता था. सो मेरा जो ख्याल है, इंडिया थोड़ा डिफरेंट है. इंडिया में क्लॉटिंग फैक्टर हमें चाहिए, ठीक है, ब्रेक थ्रू ब्लीड के लिए बहुत ज़रूरी है, सर्जरी के लिए बहुत ज़रूरी है, बट प्रोफाइलैक्सिस में या तो एक्सटेंडेड हाफ लाइफ क्लॉटिंग फैक्टर बेटर है या जो नई नॉन फैक्टर थेरेपीज़ आ रहे हैं वो ज़रूरी है. मैं इसको इस तरह से देखती हूँ, जैसे पहले जब लैंडलाइंस ही होते थे तो बहुत सारे गांव कनेक्टेड नहीं होते थे. Many places were not connected when we had landline telephones. अब जब सेल फोन है तो सबके पास फ़ोन है, आप रिमोट से रिमोट एरिया में you can, everybody is connected. So I think India is different. We sometimes need technology, and I think one of the important technologies is going to be the non-factor therapies, whether we're looking at monoclonal antibodies, whether we're looking at rebalancing agents. ये हमारे लिए बहुत important है. कुछ प्रोडक्ट्स आ रहे हैं अभी इंडिया में, कुछ ऑलरेडी हैं. आई थिंक फ्यूचर में दीज विल बी वेरी यूजफुल. एक तो सबक्यूटेनियस इंजेक्शन है, इंसुलिन के इंजेक्शन मुझे याद है मेरी नानी, मेरी दादी अपने आप ही लगा लेती थी. तो दिस इज़ अ सिंपल थिंग. इंट्रावीनस इंजेक्शन में वी डू वर्कशॉप्स, वी डू ट्रेनिंग, बट इट इज़ अ स्किल, एंड इवन with the skill sometimes some persons have very fragile, very small veins. It's a torture. So I think we are in a new era. अब आगे कैसे होगा we'll have to see. अभी जब new products सब आएंगे, how we figure that out, but I think that's going to be a game changer.
एक सेंटेंस में ऐड करूँगी कि अभी हमें पेशेंट को ऑन डिमांड नहीं रखना है. we should be on demand. Keep demanding to the authorities, bureaucrats. तो ये जो 17 अप्रैल का 26 का हीमोफीलिया डे है उसका एक लोगो रख देते हैं, अपने एक प्लेस ले लो कि आई विल आस्क फॉर द लैब अवेलेबिलिटी, कोगुलेशन लैब, एज वेल एज आई एम कीप ऑन डिमांडिंग. डोंट बी डिसहार्टेड और डिस्करेज नहीं देते. पहले तो हम ब्लड प्रोडक्ट ही यूज़ करते थे ना, आज यहाँ तक पहुँच गए ना सब क्यों देने के तक. नॉन फैक्टर वी आर यूजिंग, तो वी आर नाउ ऑन डिमांड. Every time, whenever I have a chance to talk in any function also, always talk for the hemophilia and keep demanding. So they will realize, yes, ये genuine है, हर बार यही बात करता है. So this is what I suggest.
Thank you, ma'am. Now I am aware of the time, and hence we'll jump to the last question. So आप लोगों ने already बात किया हुआ है prophylaxis के बारे में, patient convenience के बारे में. What are the factors that you look at when we are looking forward to the newer non-factor prophylactic therapies? Patient convenience हुआ, ease of use हुआ, reduced bleeding impact on quality of life, and how while you're counseling your patients, while you are putting your words again in front of the authorities, how do you approach the counseling bit for these newer therapies?
वेरी वेरी इम्पोर्टेंट. यस्टरडे ऑल्सो मैं बात करेली आना ज विषय कि पेशेंट को यू हैव टू काउंसिल इन ए सच ए वे कि वो आपकी बात ही माने, किसी और की नहीं माने. यू हैव टू टॉक लाइक दैट. इसमें मोस्ट इम्पोर्टेंट यू शुड हैव ए एविडेंस बेस्ड डेटा. एज आई ऑलरेडी काले भी कहलूँ कि WFH गाइडलाइन यू कैन यूज़, अदर स्टेट जो लोग कर रहे हैं काम उसके डेटा के भी देखो इतने इतने पेशेंट ने ये प्रोफाइलेक्सिस लिया तो हाउ मच बेनिफिट उनको कितना मिला। और हम लोग एक और फैक्टर भी यूज़ करते हैं कि वो पेशेंट जो ऑलरेडी ऑन प्रोफाइलेक्सिस पे है उनको भी काउंसलिंग में बिठाते हैं, तो वो अगर अपना वर्डिंग्स देंगे कि नहीं भाई हमने तो मैंने लिया, पहले मुझे भी लगता था कि ये क्या है ब्लीडिंग होगा तब लूँगा, अभी क्या हर रोज़ उस पर ध्यान देने का, नाउ दे फील हाउ दे फील कि अभी मेरे को बहुत अच्छा लग रहा है। तो दैट टूल इज़ ऑल्सो वेरी इंपॉर्टेंट कि द पर्सन हु इज़ ऑलरेडी बीन बेनिफिटेड एंड व्हेन दे शेयर देयर दिस एक्सपीरियंसेस that will again help you to for conversation. So first and foremost thing is the counseling of the patient. Ask them to it is a long standing process and you have to adhere with this, and other part of the everything we will take care of you. Or you need not require to for waiting. The availability of product is, if it is not there, if any case, so we will inform you on telephonically. That is what we are doing. And our from HTC we are doing one more thing. Our nursing staff and the paramedical staff, they inform our patient, those who are already on prophylaxis, day before the day they have to come. So they will also feel good that oh, somebody is taking care of us. So keep the patient in your confidence that there is somebody who is taking care of you, but you have to just keep the trust in us that we are doing best for you. So this is all will be the key for the success of the prophylaxis and adherence to the treatment protocol. Of course, again the revolution is coming, and we are also very eager to use at-home therapy. We are definitely going to convince our bureaucrats. Some of the patients, those who are difficult or caregiver also has to એમની સાથે એમને આવવું પડે છે, એમનો આખો દિવસ બગડે છે. So all these economical factor also will able to explain. So home therapy is one of the best tool again for the prophylaxis evolution. So I think ultimately मैं तो हर बार यही कहूँगी, सबको थोड़ा ऐसा लगता है कि हमारे में तो अवेलेबल नहीं है क्या करें, लेकिन your goal should be high. नहीं है नहीं करेंगे ऐसा नहीं, goal should be high कि yes one state is doing, तो prophylaxis for all, it is the only the goal. Regular replacement, we should not wait for the disability to come or any bleeding episode. So just goal high and again on demand बन जाइए आज से आप, keep demanding to the authorities. So these all are the factors that for success of these patients.
Dr. Tulika, your thoughts?
So I agree with everything, and just wanted to say that many times when we talk to the government, many of the persons in the NHM, either in the state or center, are from finance, so they're accountants or chartered accountants. So another thing that we can do and we have done is that we've done some health technology assessment, health economics papers, and those things are very useful for them to understand, okay, what is going to be the cost implication? Are we going to be going over budget, or can we do it within the budget? So I think all the companies need to look at this, and also doctors, if you can do these kind of studies, it will be very useful for them to understand what our needs are.
Thank you, ma'am. Thank you both Dr. Parul and Dr. Tulika. I'm sure there would be some questions, but the experts are here with us and we need to move on with the agenda. So with that, I thank you on behalf of the Pfizer medical team for hemophilia. I'd like to thank you all for the patient listening. Thank you to the panel for addressing the queries, concerns.
Anybody has their views, we can give them 5 minutes. If anybody want to have their views on all these things, how the home therapy will be more useful or something like a
Everyone fully understood, so no questions. I said.
Good afternoon, ma'am. Doctor, I'm speaking as a women's group coordinator from Calcutta chapter. In our group, we see that women carriers and women with bleeding disorders face specific challenges with existing therapies. Now, factor products aren't always practical. During heavy menstrual bleeding, dosing is difficult to adjust around cycles and pregnancy, and many women still go undiagnosed or undertreated because symptoms are dismissed as normal. Now, from your experience, how would you bridge the gap with the current therapy options for women, if available, and looking at new therapy classes like subcutaneous and non-factor treatments? How could they address issues like treatment burden, access during menstruation, at childbirth, postpartum, and over quality of life for women?
So this is a really important issue, and in fact, because I sometimes go to the Department of Social Justice and Empowerment, so I ask them that can we come up with guidelines for disability for von Willebrand and other disorders. So the answer I got was no. So the thing is that you will have a lot of work to do. I've already spoken about this to Mr. Prem, and we've actually already made the guidelines for disability for VWD because we wanted to try to see if the government would agree to this, but they did not. So please, there is the rare bleeding disorders. We have so many women with factor 13, with factor 10, with factor 7 deficiencies, and these are very, very serious disorders. Then there are the platelet function disorders like Glanzmann's thrombocythemia, Bernard-Solier, and many women, we know that they have some defects. Sometimes we're not able to understand, and you've already highlighted that there are some hemophilia carriers. Now the problem is that there are 22 recognized disabilities by the government of India. If you have factor 10 deficiency or you have something else, you are not covered. So there's two options. One is that you can apply under the rare disease. There is a policy for rare diseases, and these are called rare bleeding disorders. So you can apply through that. The other and I think you should do that. But side by side, we need to create and generate awareness about women bleeders so that the government recognizes them and gives them a special category, because women will have so many things in life. You have your normal menstrual cycle every month, then you have pregnancy, delivery, there may be other trauma and other things. We don't have any facilities for that. Most of the time, some factor is given to VWD patients or to the carrier patients from the hemophilia corpus that we have of factor, but it is not separately designated for women as it should be. So there is a lot of work to do. We've come far, but we have to go much, much further. Much work to do.
Thank you.
I have one suggestion for HFI, Mr. Prem, that next onward, whenever you keep such a gathering, please call some gynecologists also, because this is really needed for the women bleeding disorder point of view, because once the menorrhagia or something like that will first go to gynecologists, and they start doing a hormone assay like FSH and LH and all these things, and they lastly they may not think about the hemophilia. So I think we should include the after hysterectomy they will sometime think of. So I think we should a multidisciplinary approach, and I hope gynecology should be part of this meeting. This is what I say. So we can catch the patient earlier before the major surgery like hysterectomy and XYZ. So this is the solution only for women bleeding. Gynecology should be approached.
Thank you. Thank you.
Thank you. Thank you.
Big round of applause, everyone. Thank you so much, Dr. Amod, Dr. Parul, Dr. Tulika ma'am.
We are procuring drugs, both factors and non-factors. But at times so happens that when a vendor is being selected, but when we need the product, they tell that the product is not available in Indian market. Even months together we wait. The product is not available, whether it's a non-factor or even a factor.
So I think when you do your tendering, you should put in penalties for non-supplying, right? So we need to get smart about how tenders are done. The other thing is, rather than giving one company the full tender, you can divide that. Maybe, okay, the person who wins the tender may give 70%, 30% from somebody else, or 50, 60.
We are also doing that.
But you must put penalties.
We are also imposing penalties.
Then we just have to have no more wars and better supply.
We are undone. When so they should increase their production, and they should be made available in India. Thank you. Yeah.
Actually, ideally, there should be a national tender, and we should all the states should communicate what the needs are, because one state may suddenly increase its need, the other states may not be aware, and that's where it happens. Unfortunately, India is a big country, but I think we should move towards at least regional tenders, maybe, and that way every company also will know, okay, next year what is the demand going to be. So, very good question. Yeah.
So, at the national level, we can go for a national tender. NHM can do it at the Government of India level. HFI can also suggest to NHM to go for a national tender. इसमें आप इतना दो और इतना दो, मजबूरी अभी सभी प्लाज्मा डेराइव पर चल रहे हैं रिलायंस के द्वारा, और कहीं से कोई नहीं, अभी इतने सारे कंपनी भी यहाँ भी आए हुए हैं, लेकिन किसी ने टेंडर में पार्टिसिपेट नहीं किया था एक्सेप्ट नोवो, और भी सिंगल टेंडर हो गया था। कोई पेमेंट का इशू नहीं था, एवरीथिंग डन। अब नहीं पार्टिसिपेट किया, अब आप बताइए इन लोग को कैसे आप। नो पेमेंट का कोई इशू नहीं है, कहीं कोई पेमेंट का इशू नहीं है, स्टेट फंड भी है, एनएचएम का भी फंड है।
Thank you so much. Thank you so much, everyone. We are
Ma'am,
close.
it is very correctly said by sir, because at times government have the things that they have the budgets, and but the company is that there is only one bid, and then tender has to be it is gone because it's a single bid. Then you have to submit your urgencies. And one more thing.
So unfortunately, I don't do tenders. I'm in an autonomous institution. But I think this is a very important topic. I completely agree. And I think HFI is the best people who can sort this out. So I wish you good luck and all the best for that.
Because this helps
I
in
agree.
Breaking how to maintain the sustainability for the patient,
So true,
the supply
so true.
chain.
Yeah.
And that time government
And unfortunately, some of it is because of the price fixation that has been done, which is very low. So I think, for everything we need a balance.
Ma'am, no. This time for the Haryana part, I did not put it over there because I want that something solid should be there in my policy. Otherwise, in the last year, there was a tender for the plasma derived, and we split it between Reliance and the Intas. And Intas, after getting the supplier being the L1, they did not supply us to 20,000 vials. We were stuck.
That's bad.
The only part is that we contested with the authorities that no, whether it is the two companies, and even if it is the L1, we will go for 70-30, as you just said. And we went ahead. That is how the Reliance was able to make up. But then what?
No, I think you've raised a very important point,
it's
because
very difficult situation for us.
the dream of prophylaxis will only happen if we have enough product. If we don't have product, we can't do prophylaxis. So true, so true.
So it's just the farmers also, we want they should be collaborating with that. Yeah. Yes.
Thank you so much, everyone, for the insights and questions. I hope आप सभी के answers आपको मिल गए हैं. लेकिन अगर आपको फिर भी कोई questions है, our doctors are here in the lunch hour. आप उनको पक्का grab कर सकते हैं. लेकिन उनको lunch पहले करने दीजिएगा. And let's felicitate Dr. Amod Tilak sir, very lovely host. I request our president, Mr. Prem Rupalwa, to felicitate him. Ma'am, please. And now I request Pfizer team to come on the stage. They have been our great support, and we want to felicitate him for their extended support. I call Ms. Prishita Khare, Dr. Amod Tilak, Dr. Hitesh Mule, Mr. Chandrasekhar Agarwal, and Mr. Kishore Gupta. Please be on stage. I request Mr. Vinod, EC of Hemophilia Federation India, to join us on the stage. I'm going to tell that. So I'm closely connected with the Pfizer, so I think I should also come in the photo, yeah? So we have a short survey for you everyone. आप सभी के पास कुछ पेपर आएगा, उसे आपको 3 टिक्स में कंप्लीट करना है. It's not very big survey, but it will help our researchers, our teams to acknowledge और इसे evaluate करने में कि कैसे हम आगे रिसर्च कर सकते हैं. So please help with the survey. Once done, kindly submit it to the nearest volunteer. So now we almost reached to very important session, that is bleeding disorder with women, or this is something about the women power और वो कैसे cope up करते हैं हर situation को, and how the access is increasing and making the treatment better for all the women with bleeding disorder. That session is going to be taken by Dr. Lutika Nepram from NEIGRIHMS, Shillong. So I request ma'am to come forward on the stage. everyone done? बहुत छोटा सा सर्वे है, फटाफट हो जाना चाहिए. अभी done ना? So everyone, attention here. Next session शुरू होने जा रहा है. All the women in the hall make a clap. Only women. And all the gentlemen now. Now women please silent. Only gentlemen. Okay. Now the gentlemen please stop. Only women. यहाँ पे women कम है लेकिन उनका आवाज़ ज़्यादा है. Okay. So women power already won. And we are ready with the next session. Over to you, ma'am.
A very good afternoon to you all. So at the outset, I would like to thank President HFI, Mr. Prem Rupalva, and the organizing team of Hemophilia Federation India for giving me this opportunity to speak on this wonderful, exciting topic, increasing access to treatment for women with bleeding disorders. So World Hemophilia Day 2026 is tomorrow. And I wish you a very happy and blessed World Hemophilia Day 2026. So the theme of this year is Diagnosis, First Step to Care, which highlights the critical importance of diagnosis, the very essential first step in treatment and care. And as per the WFH data, there are more than 3/4 of patients who are undiagnosed as yet. And so hundreds and thousands of people with bleeding disorders do not have access to care. Now let's look back to the theme of 2025, Women and Girls Bleed Too. This brings us to the topic of today, where women and girls with bleeding disorders represent only 4.5% of the people identified as having hemophilia, where the expected is around 30%. So we are a long way behind, and approximately 1 in 5 women who suffer from heavy menstrual bleeds have an underlying bleeding disorder. And they have several conditions associated with it, like anemia, bleeding during pregnancy, and various other types of bleeding issues. Now they face major challenges. We've been discussing about women with bleeding disorders, and so the challenges, let me just explain to you about the major challenges that they face. Number 1 is delayed or limited access to diagnosis. Symptoms are mistaken for other conditions. For example, for low bleeds which bleed into the joints, joint pains are there, and the patient or the lady may be mistaken for having arthritis, very commonly. And then they are not taken seriously, and the bleeding episodes or the pain that they go through, they don't take it seriously because they are so involved with the care that they take for their family that they forget themselves, and then they don't take the symptoms that they have seriously, so they delay their access to medical care. And then there is normalization. Suppose a lady is bleeding heavily, and when the physician asks for the bleeding history or menstrual history, and then starts taking the family history, there may be a lot of other women in the family who have bleeding disorders, heavy menstrual bleeds, and then the physician, we tend to say that, okay, it's normal in the family, and take it for granted that maybe it is part and parcel of the family genetic system, and then we don't give a thought to bleeding disorders. Secondly, the stigma and discrimination associated with women with periods. cultural and social stigmas surrounding menstruation and bleeding disorders. In my community also we have a lot of stigma associated with periods, and this is the same story around the world. And they feel ashamed or embarrassed and prevents them from seeking medical help, which affects their social interactions and mental health and thus reduce the quality of life. We always see, it's a common phrase spoken or told by many women, that she spends a lot of time in the toilets and feared people would wonder whether she was trying to escape her schoolwork. So this is a common scenario which we can relate to many of our women and girls with bleeding disorders. The third is limited access to specialized care. Access to specialized care and treatment for women is limited in many countries. Even so, more so in a country as well, that we see gender bias prioritizes male treatment first. So these are some of the aspects that we see which hampers the enhanced access of treatment for women. Then the fourth point is lack of research and data collection. They are underserved and underrepresented in surveillance and medical databases and researches. So when they go through these bleeding issues, they suffer from pain during periods, they suffer from anemia, iron deficiency, hospitalizations, maternal mortality, limitations in daily activities, and their time is lost from work or school, and then they have adverse psychosocial aspects and reduced quality of life, and then they may have to undergo unnecessary procedures. So in general, they are underdiagnosed, underserved, unrepresented in surveillance and medical databases. How prevalent are bleeding disorders in women and girls with bleeding disorders? I have taken two studies. This one, the first one has been conducted in AIIMS, New Delhi. Ma'am is there, Ma'am Tulika Seth. Spectrum of hemostatic disorders in Indian females presenting with bleeding manifestations, which was published in 2017. And another one, which was, the study was undertaken in Kochi by Abraham et al. In 2023. Where I have given the comparative study, the AIIMS study and the Kochi study showed approximately similar 34 to 35% of the women and girls with bleeding disorders being majorly due to von Willebrand's disease. In the AIIMS study, Glanzmann's thrombasthenia was the next. They also had multiple others, major being factor 7 deficiency, factor 10 deficiency, and factor 1 deficiency, as ma'am has also mentioned. In the Kochi study, they had factor 7 deficiency as the next, then vitamin K dependent clotting factor deficiencies, acquired hemophilia A, etc. So some of the major disorders I have given. Now, regarding the bleeding manifestations, in the AIIMS study, they found spontaneous bruising in 51.4% of the patients, petechiae, epistaxis, menorrhagia, etc. And in the Kochi study, menorrhagia was the most common, 34.4%. Next, we come to what initiatives are being taken to address this issue of women and girls with bleeding disorders. This is an initiative taken by WFH, World Federation of Hemophilia, known as Women and Girls with Bleeding Disorders Initiative, which aims to increase equitable access to diagnosis and care for all women and girls with bleeding disorders, increase their recognition and visibility within the broader bleeding disorders community through global awareness and collaboration on WGBT issues, and increase data collection on women and girls with bleeding disorders, as we have discussed already. Now, this is achieved through three key components. One is capacity building, awareness raising, and data collection. In capacity building, it aims to increase the knowledge of healthcare providers on comprehensive clinical management of women and girls with bleeding disorders, which we are really lacking. Increasing the capacity of national member organizations to advocate the right to equitable access to care for women and girls with bleeding disorders, and increase the knowledge of healthcare workers, healthcare professionals, and women and girls with bleeding disorders through peer-to-peer support and exchange. Next is raising awareness to increase the recognition of these group of people by enhancing the WFH global action to raise awareness about women and girls with bleeding disorders worldwide, strengthening collaboration between WFH, civil society, and other stakeholders interested in supporting women and girls with bleeding disorders, and promoting the engagement of women and girls with bleeding disorders in WFH programs, which we have not done so. I mean, in other countries, it's beginning from 2021 itself, but in our country, we have not gone ahead as yet. Then the third is data collection, by enhancing capacity on collection and reporting data on women and girls with bleeding disorders among national member organizations and hemophilia treatment centers, and increasing the WFH's data collection efforts on women and girls with bleeding disorders. Now, yesterday it was mentioned about the ISTH new nomenclature on hemophilia with women and girls with bleeding disorders. In 2021, the ISTH, International Society of Thrombosis and Hemostasis, they came up with a new nomenclature that was so done because the term hemophilia carrier can hamper diagnosis, clinical care, and research, as we all know, and we have discussed, and we all have seen it. So there are 5 categories: women and girls with mild hemophilia, women and girls with moderate hemophilia, women and girls with severe hemophilia, symptomatic hemophilia carriers with bleeding symptoms even though their factor level rate is more than 40, or asymptomatic hemophilia carriers without bleeding symptoms. So these are the 5 different categories, new nomenclature on hemophilia in women and girls. Now, this has been explained already. Because of lack of time, I will not go into details. But I just want to explain about lionization, which was also mentioned yesterday, that because of lionization, there may be a mosaicism of bleeding disorders, bleeding manifestations in different women. So some of the bleeding symptoms specific to women, apart from the regular bleeding symptoms that we see in both men and women, are heavy menstrual bleed and postpartum bleeding. So specifically, gynecological manifestations, you have menstrual pain, cramps, and mid-cycle pain. And then there is a term called Mittelschmerz pain, that is the internal bleeding during ovulation, which can become life-threatening as well. Then they have irregular cycles, there may be fibroids, uterine or cervical polyps. And then the functional ovarian cysts may happen during the ovulation period, risking bleeding into in these patients. Endometriosis rates go up, and joint diseases, as I mentioned, may be mistaken for arthritis, and then there may be perimenopausal heavy bleeding in patients during the menopausal time. Then we have the obstetrical manifestations, bleeding with miscarriages and postpartum hemorrhage. Now, how do we diagnose? Just a little bit, just to make you all understand about what women go through, what kind of diagnosis and all. So personal and family history is extremely important. Medication history has to be taken, whether they are on antiplatelet drugs or NSAIDs or on oral contraceptives. And then we have the BAD score. BAD score has to be taken, and there is another charting system which is very essential, pictorial blood assessment chart, which helps in analyzing the kind of bleeding the woman is going through. Then we have different types of parameters that we have to see in the laboratory. And then just a word about the factor level. They may be falsely normal in women. During pregnancy, or it increases. During stress, it increases. During inflammation, infection, it increases. So they may give false results, and when the baby is delivered, it may go down. So factor levels have to be taken very cautiously, and then we cannot come to a total conclusion and that the patient is suffering from hemophilia with 1. So it has to be properly analyzed. Then this is some of the management which one ma'am was raising about. If this is just a simplified chart, a gynecologist will be in a better position to explain. But just to give you a gist of how can a woman or a girl with hemophilia or other rare bleeding disorders can be managed. If the patient is wants to preserve fertility, if past the age of reproduction, then no. Then the patient can undergo endometrial ablation or hysterectomy. If yes, then if the patient wants to undergo pregnancy now, or not? If no, then we can start with hormonal therapies. If not, if yes, and the patient wants to start pregnancy now, then she has to be given antifibrinolytic drugs like tranexamic acid, epsilon aminocaproic acid, desmopressin, and clotting factor replacement as the requirement. So, how to increase the access to care for women and girls with bleeding disorders? They are usually deep, as I have mentioned also, that they are deeply involved in looking after their family. They find difficulty in accessing services. So we have to have flexible approaches like telemedicine, outreach programs to involve them and to give them services. So in conclusion, over the last several decades, World Federation Hemophilia has made efforts to improve diagnosis, treatment and care to improve quality of life in women and girls with bleeding disorders through the Women and Girls Bleeding Disorders Initiative. Data and research into general bleeding symptoms in women and girls with bleeding disorders is needed to support and improve comprehensive care in future, and a lot of work still needs to be done. That's the end of the assessment as of today, especially in our country. Thank you very much.
Thank you so much, Dr. Lutika ma'am, for that insightful session. और मैं देख रहा था सारी women's एकदम ध्यान लगा के ये सुन रही थी. So hope आपके कुछ views change हुए होंगे इस session के बाद. I would like to invite Mr. Subhashish Behra sir to come forward and felicitate ma'am. मैं आपको भैया बोलता हूँ ना तो भूल गया. नहीं फिर बहुत सारे आ जाते हैं. So let's move into the next session. और उस session का part मैं खुद हूँ तो it's not good कि मैं अपने बारे में कुछ बताऊँ. तो I would like to request Miss Shreya to come forward and take over the mic.
Hello everyone, my name is Shreya Kundanhalli from Hubli chapter. I am currently pursuing Bachelor's of Engineering in Computer Science. I would like to welcome the chief guest. First is Sandeep Pandey. He is a key member of Hemophilia Society Varanasi, a founding member of the youth movement in India and actively contributing to awareness and community support initiatives. Next we have Subhashish Behra. He is a 37-year-old assistant professor of computer science at Dharanidhar University, Odisha, and a severe hemophilia A patient. He serves as a president of the Hemophilia Society, Bhubaneswar chapter and regional council chairman East of the Hemophilia Federation of India. He holds an MTech from NIT Durgapur and is a devoted husband and a father to a 2.5-year-old son. Next we have Saurabh Nalamwar. He is the youth chairman from the Nashik chapter, a speaker, leader and a visionary and the founder of Brilverse Technologies. Next we have Apurv Khator. He is also a hemophilia A patient and a lawyer practicing in Delhi who enjoys swimming and reading in his free time. Next is a chairperson for this session, Niranjan Saxena. He is an active volunteer with HFI He currently works as a product manager with computer science degree from DTU and an MBA from IIM Ahmedabad. Thank you.
Thank you so much, Shreya. So we'll be starting this session, and I want to kind of explore what this whole platform is all about. So हम यहाँ पे सब आते हैं and we talk about a lot of things in terms of medicine में हम क्या चल रहे हैं, हमारे patients वगैरह कैसे कर रहे हैं, what are the healthcare benefits that are needed. But there's a perspective that I wanted to bring, which was around patients. उनकी daily life की stories वगैरह कैसी हैं, and how does it go around in terms of dealing with most of the challenges that they face in their life, and how they evolve over time with this. And the idea behind this, that they want to, they have all done fantastic jobs in their lives, and they are moving towards a direction जहाँ पे they have reached a place and they have found their own identity. Now, all of those underlying aspects of education, identity, and their independence as well, I want to bring. So we'll start with a couple of questions around those, and we'll see what kind of stories that you can possibly get out of these people. So I hope everyone has a mic, right? We can pass it around. Okay. So I'm going to be delving into a couple of different topics, and we'll try to keep it in Hindi and English both, so that everyone kind of follows along. So the first question that I kind of want to highlight is diagnosis, right? आप लोगों को पता कैसे लगा कि what was your how you came to know कि आपको हीमोफीलिया है, आपकी फैमिली का क्या रिएक्शन था, and just basic stories around कि how did you all handle that? So anyone wants to go ahead first?
हेलो, सभी को नमस्कार. मैं संदीप पांडे, हीमोफीलिया सोसाइटी वाराणसी से. और मेरे जैसे कि भाई ने बोला कि कैसे पता चला और क्या रिएक्शन था फैमिली का, तो चूँकि मेरे बड़े भाई साहब को भी हीमोफीलिया है, वी बोथ आर हेमोफिलिक एंड सीवियर हीमोफीलिया ए लेस देन 1%. तो फैमिली में सभी लोगों ने देख लिया था बड़े भाई को कि वो भी हीमोफिलिक है, और उनके फैक्टर उपलब्धता तो थी नहीं उस समय, और जॉइंट्स वर्सन होने शुरू हो गए थे बार बार फ्रिक्वेंट ब्लीड की वजह से. तो जब मैं लगभग 4-5 साल का हुआ तो कुछ सिम्टम्स started in my body, bruises and all started appearing. So हमको भी diagnosis कराया गया. I mean audible. तो मुझे भी diagnose कराया गया, तो I became hemophilia A, और तब से I was on treatment. मेरे समय में तो treatment था भी नहीं, वही whole blood, we started taking whole blood, plasma, cryoprecipitate. Now we are talking about gene therapy and all ना. उस समय तो हम लोगों के सारे बस वही पापा से ब्लड उतार के हम लोगों को लगता था, दोनों भाइयों को. और यही सेम स्थिति मोस्ट ऑफ हमारे जो उसमें एज में रहे होंगे सभी के साथ यही था, होल ब्लड उतार के लगवाना या फिर प्लाज्मा. हम लोग तो बहुत बाद में फैक्टर देखना शुरू किए. तो लकीली आई वाज सो फॉर्चुनेट टू बी सेलेक्टेड इन द प्रोग्राम. हीमोफीलिया सोसाइटी से स्पॉन्सर्ड हुआ, और हम लोग कुणाल कोटेचा और मैं 2005 में वी आर बोथ सेलेक्टेड फॉर स्किल डेवलपमेंट काइंड ऑफ प्रोग्राम फॉर 3.5 months इन डेनमार्क. फिर हम लोग जब वहाँ पे गए तो देखे कि यूथ की इतनी बढ़िया एक्टिविटीज़ वहाँ पे थी. तब तक हमारे इंडिया में यूथ को कोई जानता भी नहीं था कि कुछ यूथ है और ऐसा कुछ था. और सारे बच्चे वहाँ पे सारे गेम्स खेलते थे, सब कुछ उनकी लाइफ बड़ी अच्छी थी, बहुत मस्त वाली लाइफ होती थी. और हम लोग यहाँ पे परेशान हुआ करते थे, यार ये फैक्टर नहीं है, ये है, डिसेबिलिटी भी होती थी. तो वहाँ पे जब टर्कल एंडरसन साहब थे, ही वाज द प्रेसिडेंट ऑफ डेनिश हीमोफीलिया सोसाइटी. हम लोगों ने फिर उनसे बात करी कि सर हम लोग यूथ अभी हम लोग बहुत अननोन हैं इंडिया में, और हम लोग अभी एक पूरी तरह से लाइट में आए ही नहीं हैं. हम लोग अपनी लाइफ जी तो रहे हैं, लेकिन समझ में नहीं आ रहा कैसे करना चाहिए, क्या करना चाहिए. तो उन्होंने बोला कि यूथ के ऊपर आप लोग काम करो, and then we both started hemophilia movement in India in 2005-6. और अनफॉर्चुनेटली हमारा छोटा भाई जो कुणाल कोटेचा जो हमारे साथ अभी नहीं है, लास्ट ईयर थ्रोट कैंसर की वजह से शायद वो नहीं है हम लोगों के बीच में अभी, और हम दोनों ने फिर इस मूवमेंट को स्टार्ट किया, फिर प्रेम भाई और मुकेश हम लोगों ने फिर इसको लेकर आगे चले। तो कहानी तो बहुत लंबी है, बीच बीच में हम लोग बात करते रहेंगे। तो
थैंक यू। तो ये यहाँ पे मैं जब छोटा था, पैदा हुआ, तो इट वाज अ वेरी रिमोट डिस्ट्रिक्ट ऑफ ओडिशा। तो फर्स्ट ऑफ ऑल डायग्नोसिस करना काफ़ी मुश्किल था। तो वहाँ पे पता ही नहीं था कि लोगों को हेमोफिलिया है। तो ब्रूसेस तो जैसे आते थे पहले, जब जन्म पैदा हुआ मैं, तो जब एम्बिकल कॉर्ड जो काटा गया तभी मेरा प्रोलॉन्ग्ड ब्लीड हुआ था। तो उस समय तो पता ही नहीं था कि हेमोफिलिया है कि नहीं है। तो वो सबको पता था कि बहुत देर तक ब्लीड हुआ था। फिर जब मैं 1 साल का हुआ, फिर स्टेप्स जब उतरता था तो गिरता था, तो फिर यहाँ पे चोट लगती थी। सो यहाँ पे ब्लीड होता था, मतलब इंटरनल स्वेलिंग होती थी, तो ये सूज जाता था। तो वहाँ पे एक बार पापा लेके गए थे एक हॉस्पिटल, तो वहाँ पे पहली बार एक डॉक्टर ने, वही रिमोट तब के ज़माने में, इन द ईयर ऑफ 90, तो तब के ज़माने में वो डॉक्टर साहब बोले थे कि इट मे बी ए केस ऑफ हेमोफिलिया, सो यू गो फॉर डायग्नोसिस। एंड तब इंडिया में बहुत कम जगह पे होती थी। तो मेरा पहला जो हेमोफिलिया डायग्नोसिस हुआ था, तो वो हुआ था BHU में। हाँ, तो वहीं से पता चला हमें।
ओके, क्योंकि हमारे पास बहुत सारे क्वेश्चन हैं, वील कीप ऑन। हाँ, बिल्कुल।
30 सेकंड्स ऐड करना चाहूँगा कि आपने जो क्वेश्चन पूछा पहला वाला ही, दैट इज़ राइट टू द मार्क। वर्ल्ड हीमोफीलिया डे का इस बार का थीम ही एक्सेस टू केयर है, डायग्नोस्टिक्स वाला। एंड वर्ल्ड फेडरेशन भी ये समझता है कि डायग्नोसिस इज़ द की टू द सॉल्यूशन। अगर किसी भी पेशेंट को हम मुख्य प्रवाह में लेके आए बहुत जल्दी, एज के बहुत पहले, तो ये जो डिफॉर्मिटीज़ होती है, जो प्रॉब्लम्स आती है, जो करियर वो डेवलप कर सकते हैं, उससे हम अच्छा कर सकते हैं एट वेरी अर्ली एज। तो डायग्नोस्टिक्स इज़ अ वेरी क्रूशल पार्ट। और इस थीम को कंटिन्यू करते हुए यहाँ पे बहुत सारे स्टेट्स हैं हमारे पास, नोडल ऑफिसर्स है, NHM के ऑफिसर्स है। सो उनको एक रिक्वेस्ट है कि आप जितना हो सके उतना ज़्यादा से ज़्यादा डायग्नोस्टिक्स पे फोकस करेंगे, तो शायद हम नंबर्स बढ़ाएंगे। लेकिन नंबर्स बढ़ने के बाद जो हमारा पेशेंट्स का काउंट बढ़ रहा है, लेकिन उनका केयर जो है वो ज़्यादा बढ़ेगा, उनकी डिफॉर्मिटीज़ ख़त्म हो जाएंगी, उनके जॉइंट्स अच्छे रहेंगे, एंड दे विल हैव अ नॉर्मल लाइफ। स्कूल्स कर पाएंगे, अपने जॉब्स में वो अच्छा परफॉर्म कर पाएंगे, दे कैन डू द वंडर्स इन द बिजनेस एज वेल। तो हमारे भारत का जो प्रोग्रेस है उसमें उनका कंट्रीब्यूशन शुरू हो जाएगा। तो आई थिंक दैट इज़ द पॉइंट आई वुड लाइक टू पुट इन दिस वेरी सिनारियो। या
थैंक यू सो मच सौरभ। नेक्स्ट आई वांटेड टू टॉक अबाउट लाइफ चेंजिंग इंजरीज। फॉर मी पर्सनली, मेरी लाइफ में एक 8th क्लास में इंजरी हुई थी, जिसकी वजह से आई वॉज बेड रिडन फॉर ऑलमोस्ट 2 years, एंड मेरी एजुकेशन पे बहुत ज़्यादा इम्पैक्ट आया था। एंड टॉकिंग अबाउट दैट, आई वांट टू अंडरस्टैंड फ्रॉम यू गाइज एज वेल कि आपकी लाइफ में ऐसी कोई लाइफ चेंजिंग इंजरी रही है और आपने उससे कैसे उभरा। बिकॉज फॉर मी पर्सनली, मेरे लिए था कि मेरा स्पोर्ट्स एंड खेलना सब कुछ ख़त्म हो चुका है अभी इस पॉइंट पे। नाउ आई वांट टू फोकस कम्प्लीटली ऑन एजुकेशन, एंड मैं उन चीज़ों पे फोकस करना चाहता हूँ ताकि मेरा फ्यूचर और ज़्यादा अच्छा हो। एंड रही बात लाइफ चेंजिंग इंजरीज की, आई कांट स्टैंड फॉर लॉन्ग, तो आई गोना सिट हियर विद यू गाइस।
So for me, the life-changing injury, actually it was not single injury, it was the initial bleeds when we were in school. So when you used to have the ankle bleeds or elbow bleeds, you could not go around and play around, you could not go to school, or even if you could go to school, you could not go and play football in the games period. So of course that breaks the confidence in a child. And at that time it is very important for I feel the caregiver, which is the parents, to make sure that that confidence does not break for the children. So life changing हमेशा वो बहुत बड़ी इंजरीज नहीं होती मेरे हिसाब से, जो बचपन में आपके माइंडसेट हो जाता है कि यार मैं तो ये कर ही नहीं सकता, मैं तो ये कैसे खेलूँगा, those are the times I think जहाँ पे parents come into picture and they should always support कि भाई ठीक है, if you can't play cricket you swim, you can't play football, why don't you go and read, why don't you play chess, there are so many other things. So I think my life changing it was in a way कि मैं cricket नहीं खेल सकता तो मैं swimming कर सकता था, and I swam quite well for some time, so that's how it was.
यहाँ पे मैं बोलूँगा तो एक लाइफ चेंजिंग जैसे बोलते हैं तो यहाँ पे दो सिनेरियोज हैं. तो हमारे ज़माने का सिनेरियो अलग है, आज के डेट का सिनेरियो कम्प्लीटली अलग है. तो आई गॉट ए सीवियर एक्सीडेंट इन द ईयर 1995. तो वहाँ पे मेरा राइट लेग को फ्रैक्चर हुआ था. इट वाज ए ग्रिंस्टिक फ्रैक्चर. सो तो पता चला तब तक बेंड हो गया थोड़ा थोड़ा करके. तो वो तब के ज़माने में जैसे आज के ज़माने में हम कहीं पे भी सर्जरीज कर सकते हैं हेमोफिलिक को लेके, तब के ज़माने में सर्जरीज हेमोफिलिया में तो बहुत ही रेयर चीज़ है. हेमोफिलिया में ब्लीड ट्रीट हो जाए तो बड़ी बात है, सर्जरीज तो बहुत बड़ी बात है. तो वहाँ पे सर्जरी सीएमसी भेलोर में होना है. फिर कम्युनिकेशंस गया सीएमसी को, तो वो फंडिंग क्या हुआ, फिर फैक्टर अवेलेबिलिटी, ये सब देख के फिर 2000 में मेरा सर्जरीज हुआ. तो फिर तब तक मतलब दोनों पैर स्लाइटली लेफ्ट पैर भी थोड़ा मुड़ गया था, तो दोनों पैर में सर्जरीज हुआ. तो यही है सिनेरियो के पहले के ज़माने का इंजुरीज और आज के ज़माने में होता है. आज के ज़माने में जब भी जीआई ट्रैक जैसे कि हम इंट्राक्रैनियल ब्लीड कहते हैं तो वो बहुत ही सीरियस इंजुरीज होती है. लेकिन आज के ज़माने में हम होप कर सकते हैं कि हम एक छोटे से छोटे हॉस्पिटल, इवन भुवनेश्वर से में भी हमारे एम्स भुवनेश्वर में है, हमारा गवर्नमेंट हॉस्पिटल्स है, हमारे प्राइवेट हॉस्पिटल्स है, वहाँ पे भी हम सर्जरीज आज के डेट में प्रोवाइड कर सकते हैं. लेकिन ये उस ज़माने में नहीं था. तो इसके ऊपर हमें और ज़्यादा फोकस करना है. गवर्नमेंट सेटअप में ये सब लार्ज चीज़ें कैसे और ज़्यादा हो सके, इजीली प्रोवाइड हो सके. जैसे कि एक आम आदमी जाके जैसे सर्जरी कर सकता है, वैसे ही एक हेमोफिलिक क्यों नहीं कर सकता. इसके ऊपर हमें ध्यान देना चाहिए.
Hello. Yeah. So next question I kind of want to ask about is two separate instances of things. एक आपका disability. The word itself feels like a limitation, right? And सब लोग यही बोलते हैं कि आप when you say that word it means in an offensive way to some people. But I want to bring out the positive in that. What was something जो आपको लगता था कि नहीं ये तो मैं कर ही नहीं सकता, ये तो impossible है, but you were able to achieve that. And again around that, how do you disclose your hemophilia to other people around you through your achievements, through those other things? आप कैसे उन्हें बता पाते हैं कि I have hemophilia and how do you talk about that?
ये जो आपने बोला मुझे बहुत अच्छे ढंग से याद है. और being a hemophilic patient, being a severe hemophilic patient, I used to receive frequent bleeding in my right and left iliopsoas both when I was approximate 16-18 year old. जब मेरा एनुअल एग्ज़ाम आता था, हमारे स्टार्ट हो जाता था, तो आई लेफ्ट 4 or 5 times my 10th exam. I left. उसकी वजह से I was so much depressed कि कैसे होगा, कैसे नहीं होगा. लेकिन लकीली मैं कुछ लोगों की सपोर्ट से उस समय हीमोफीलिया सोसाइटी वाराणसी वाज नॉट इन लाइट. वी डिडंट स्टार्ट एट दैट टाइम. उसके बाद जब हीमोफीलिया सोसाइटी खुली, ऐसा लगने लगा था. और उस समय कोई फैक्टर नहीं था, सिर्फ ब्लड और क्रायो प्लाज्मा यही सब होता था. लेकिन पापा ने कभी भी मुझे हमेशा ही सपोर्ट किया, नहीं तुम्हें करना है करना है करना है. उस समय मैं हार चुका था कि मैं तो लगता है पढ़ ही नहीं पाऊँगा. फिर मैंने 10th कंप्लीट किया, 12th किया, पीजी किया, ग्रेजुएशन किया, पीजी डबल पीजी में किया, फिर बीएड किया. और आज अभी मैं संस्था चला रहा हूँ, मेरा खुद का बिजनेस है वो चला रहा हूँ, दाल रोटी होती है. तो मैं बच्चों से यही कहना चाहूँगा, अपने यूथ और आज के यूथ का एक सबसे बड़ा ये चीज़ है ना कि
उनको जो फैक्टर मिल रहा है अभी, गवर्नमेंट सप्लाई मिल रही है, चाहे STCs HF का फैक्टर मिल रहा है, उस फैक्टर को वो ग्रांटेड लेते हैं। मैं बहुत ही फैक्ट बता रहा हूँ, बस फैक्टर मिल गया, ब्लीड हो गया, बस उनका कहानी वहीं पे ख़त्म हो जाता है। दे आर नॉट एक्टिवली पार्टिसिपेटिंग इन सोसाइटी, बिकॉज अनटिल और अनलेस योर सोसाइटी इज नॉट स्ट्रेंथेंड ना, तो वो आपके लिए तो काम कर रही है। ये मैं यूथ की बात कर रहा हूँ। उनको सोसाइटी की याद तभी आती है जब उनको ब्लीड होता है। रात में 12 बजे ब्लीड होगा तो सोसाइटी और संदीप भैया, चाहे सुभाषिस, चाहे कोई भी याद आएगा। उसके बाद वो बस ठीक है, ऐसे रिलेक्टेंट भूल जाते हैं। अगर ये थोड़ा सा पार्टिसिपेशन यूथ का बढ़ जाए हीमोफीलिया सोसाइटी में ना, तो हम तो उनके लिए काम कर रहे हैं और ज़्यादा भी अच्छे से काम कर पाएंगे।
संदीप राइटली सेड, बट यहाँ पे मैं एक और चीज़ फिर से बोलना चाहूँगा। तो तब के ज़माने और आज के ज़माने में काफ़ी अंतर है। तो जैसे कि हेमोफीलिया का विज़न है कि डिसेबिलिटी, हेमोफीलिया विदाउट डिसेबिलिटी, तो इसके ऊपर हम बिल्कुल काम करते हैं। जैसे आज के डेट में आपका जैसे न्यू थेरापीज़ आ गए हैं, EHL फैक्टर आ गए हैं, प्रोफाइलैक्सिस की बात करते हैं, रेगुलर प्रोफाइलैक्सिस की बात करते हैं, फिर हम फिर आगे हम ये बोलते हैं कि होम थेरेपी में कैसे प्रोफाइलैक्सिस, अगर ये न्यू थेरेपी नहीं हो तो EHL हो या फिर जो स्टैंडर्ड हाफ लाइफ वाला हो, उसमें भी कैसे प्रोफाइलैक्सिस हम घर पे जाके ले सकते हैं। इनके ऊपर हम जब फोकस करते हैं तो हम ये उम्मीद रखते हैं कि आगे चल के 5-10 साल में हमारा कोई भी हेमोफिलिक जो होगा वो डिसेबल नहीं होगा, और वो बिल्कुल भी एक सोसाइटी के ऊपर, अपने घर के ऊपर एक बर्डन नहीं होगा। ही विल रादर पुट हिज efforts a contributing human for the society and for his family। और यहाँ पे डायग्नोसिस, डिस्क्लोजर की बात कर रहे थे आप, तो डिस्क्लोजर में मैं ये बोलूँगा, जब भी हम छोटे थे तो स्कूल में गए तो पापा पहले बता दिए कि भाई ये तो हेमोफिलिक है, इसको चोट नहीं लगना चाहिए, तो कोने में बिठा दो। ठीक है ना, टीचर हो गया ना स्कूल के फ्रेंड्स हो गए, सबको पता है कि ये हेमोफिलिक है भाई, इसको कोने में बिठाओ, इसके साथ कोई मतलब दूर से ही रहो, दूर ही रहो, पास भी मत जाओ, ऐसा मतलब छूना नहीं है, मतलब वैसा ही कुछ था तब के ज़माने में, ये था। लेकिन आज के ज़माने में ये थोड़ा चेंजेस आ गए हैं, लेकिन डिस्क्लोज करना काफ़ी ज़रूरी होता है, वेदर आप शादी के लिए करो या फिर शादी से पहले करो, गर्लफ्रेंड को करो, या फिर आप चल के स्कूल में बच्चों, पेरेंट्स को करो, किसी को भी ये डिस्क्लोज करना काफ़ी ज़रूरी होता है।
So am I audible? Actually वो थोड़ा सा पैरालैक्स हो जाता है कि मेरा आवाज़ ज़्यादा है या नहीं इसमें से। तो बीइंग एन एंटरप्रेन्योर, आज मैं काफ़ी आसानी से कह सकता हूँ कि मैं एक कंपनी लीड कर रहा हूँ, बट ये ऐसा सिचुएशन शायद पहले नहीं था। माई मॉम एंड डैड, इवन एवरी मॉम एंड डैड इन द प्लानट, दे आर वरीड कि उनके औलादे, उनके बच्चे आगे चल के क्या करेंगे, काम करेंगे, या उनको जॉब मिलेगी क्या। एंड बीइंग एन हीमोफिलिक पेरेंट, ये तो बहुत ट्रिकी सा सिचुएशन रहता है कि ये अपना घर कैसे चलाएंगे, ये एक्चुअल में क्या काम कर पाएंगे, जहाँ पे फैक्टर्स नहीं है, दिन भर या हफ्तों भर इनको बैठना पड़ रहा है, तो ये क्या करेंगे। लेकिन आई एम वेरी प्राउड टू से टुडे कि आज सिर्फ मैं अपना घर नहीं, मैं कई लोगों का घर चला रहा हूँ। तो ये जो थॉट प्रोसेस है, थैंक यू सो मच, ये जो थॉट प्रोसेस है, ये किसी एजुकेशनल इंस्टीट्यूशन से नहीं आया, ये जो आया है कहीं ना कहीं ये हीमोफीलिया फेडरेशन का इसमें बहुत बड़ा योगदान है। मैं एट द राइट एज, समझिए कि मैं बहुत सही जगह पे पहुंचा। बैंगलोर में यूथ वर्कशॉप हो रहा था और वहाँ पे मुझे किसी ने पूछा कि सभी को पूछा, लेकिन थोड़ा सा उन्होंने डायरेक्ट मेरी तरफ किया था कि आप क्या करना चाहते हो, लाइफ में क्या बनना चाहते हो। एंड द एंटायर सेशन वाज ब्रेकिंग द बैरियर्स। तो मैंने वहाँ पे कहा कि मुझे मैम जॉब नहीं करनी है, मुझे कुछ तो अपना करना है, एंड आई वांट टू बी एंटरप्रेन्योर। तो आई वाज ओनली 17 ईयर ओल्ड, 18 ईयर ओल्ड दैट टाइम, और उस टाइम पे मेरा वो क्लैरिटी क्लियर हुआ और मल्टीपल मुझे ट्रेनिंग्स मिले। ओके, सपोर्ट सिस्टम ऐसा था कि मुझे उतना ज़्यादा परेशानी नहीं हुआ बट या कंसिस्टेंसी एंड डिटर्मिनेशन की ज़रूरत इसमें बिल्कुल रही और उसी वजह से ये पॉसिबल हुआ. सो एडवर्सिटी टू द तो रहता ही हर किसी के लाइफ में, लेकिन हीमोफिलिक के लाइफ में थोड़ा ज़्यादा होता है. पर उस एडवर्सिटी को हमें कैसे कन्वर्ट करना है अपॉर्चुनिटीज़ में, और अपॉर्चुनिटीज़ लाइफ के हर किसी के लाइफ में आता है. हमारे ऊपर है कि वो कैसे हम इसे पॉजिटिवली लेते हैं. तो एज ए हीमोफिलिक वी हैव लॉट ऑफ टाइम. हम स्कूल नहीं जाते हैं तो उसका जो कॉलेज में भी नहीं जा रहे, तो वी हैव अ टाइम फॉर द लर्निंग अनदर स्किल. तो इसके ऊपर हम अगर ज़्यादा काम करें, क्योंकि आज रेज्यूमेज़ का ज़माना नहीं है. हम हमारी कंपनी में रेज्यूमेज़ कभी नहीं देखते, हम उसका स्किल देखते हैं. तो सेम आप मैं सभी से कहना चाहूँगा कि स्किल के ऊपर काम करना शुरू कीजिए. देयर इज़ लॉट मोर अपॉर्चुनिटीज़. थैंक यू.
Thank you. Apur, you want to add something?
Just one thing I probably want to add is that when you say that, how do you disclose it? How do you disclose that you are hemophilic? I think one thing is that you yourself should get that stigma out of it कि यार मैं hemophila है. जो है वो है. I mean, everyone has some kind of a disease. Everyone has something or the other. You have hemophilia. Deal with it. Live with it. Once you accept it, it will be easier for you to tell the world that yes, I have hemophilia. And once you tell the world I have hemophilia, and that's just a part of it. I'm not only hemophilic. It's one part of me. And I think life will be a little more easier. It was easier for me once I accepted that yes, I have hemophilia. I can't do anything about it. Live with it and deal with it. That's the thing.
Thank you so much, Apur, and everyone else. This has been quite pleasurable कि हमें इतने different perspectives मिले हैं, and सब लोगों के लिए अलग-अलग चीज़ रही है, but support हमेशा हम लोगों को मिला है. That is why we were able to get as far as we are. Now एक चीज़ के बारे में मैं जानना चाहता हूँ कि आपकी daily life में कोई ऐसा specific challenge है जो आप face करते हो but ज़्यादा generally बताते नहीं हो outside. तो अगर आप उस टाइप का किसी को बताना है तो that would be nice. जैसे मेरे personally डेली लाइफ में मेरी बहुत सारी चीज़ें रहती हैं. कभी कभी पेन ज़्यादा रहता है तो उसकी वजह से मैं असाइनमेंट्स वगैरह नहीं सबमिट कर पाता था, तो मेरे को वो थोड़ा मुश्किल होता था उस सिनेरियो में. एंड मैं जाके प्रोफेसर्स को नहीं बोलता था कि उनको लगेगा कि मैं एक्सक्यूज़ दे रहा हूँ, राइट. तो ये चीज़ मेरे दिमाग में रहती थी, बट फिर भी मैं जाके थोड़ा सा जुटा के मैं गया उनके पास कि मैंने बताया, समझाई चीज़ें, एंड देन दे वर मोर एक्सेप्टेबल ऑफ दैट. तो इस टाइप से कोई छोटी मोटी डेली स्टोरीज, इवन ट्रैवल से रिलेटेड स्टोरीज जो आप बताना चाहते हैं.
ये मैं वही बोल रहा हूँ कि डिस्क्लोजर, ठीक है, ये डिस्क्लोजर के ऊपर आता है कि हम, जैसे मैं जब पढ़ाई करता था तब भी डिस्क्लोजर था कि भाई मैं हेमोफिलिक हूँ, तो फिर प्रोफेसर्स को भी पता था कि क्या कर सकता है क्या नहीं कर सकता है. कभी कभी एग्ज़ाम्स भी स्किप हुए हैं, एक बार हुआ है, तो ये पता था उन लोगों को. और जब रही जॉब की बात, तो वहाँ पे भी डिस्क्लोजर है मेरा कि हेमोफिलिक है, क्योंकि ये काफ़ी ज़रूरी होता है कि जब जिस जगह पे आप काम करते हैं वहाँ पे भी लोगों को पता होगा, क्योंकि ट्रॉमा कभी भी कहीं पे भी हो सकता है. अगर मुझे कुछ हुआ तो मेरे पेरेंट्स हमेशा मेरे साथ रहेंगे ऑफिस में, ये ज़रूरी नहीं है. तो उनको भी पता है कि वो कहाँ मुझे लेके जाएंगे और क्या मेरा ट्रीटमेंट होगा और मेरा किन लोगों का जो इमरजेंसी है उन किन लोगों को बात करेंगे. तो ये प्रॉब्लम्स आती है. तो जो हमारे, जैसे कि मैं गवर्नमेंट में काम करता हूँ, तो ये एक्सेप्टेबल है कि अंडरस्टैंडेबल है कि एडजस्ट हो जाती है. ये प्राइवेट में शायद थोड़ा दिक्कत होगा, इसके ऊपर मैं बोल सकता हूँ.
सो आई फील कि सारे हीमोफिलिक्स कहीं ना कहीं एक पॉइंट पे थोड़ा इंट्रोवर्ट हो जाते हैं, क्योंकि वो सोशलाइज नहीं करते हैं. उनको अपॉर्चुनिटीज़ ही नहीं होती है कहाँ पे जाए, किससे बात करे, तो वो घर पे रह के इंट्रोवर्ट हो जाते हैं. इवन सेम पार्ट ऑफ माई लाइफ वॉज समवेयर आई वॉज ऑल्सो वेरी सेल्फ ओरिएंटेड, और मैं इंट्रोवर्ट हो गया था. लेकिन ये मैंने प्रैक्टिस किया, ठीक है, मैंने प्रैक्टिस किया कि कैसे बात करना होता है, कैसे हम दूसरों के साथ शेयरिंग कर सकते हैं अपनी पर्सनल स्टोरीज़ को एंड मेक अ कनेक्शंस. तो आई थिंक ये मेरे लिए, मेरे पार्ट ऑफ लाइफ में सबसे ज़्यादा ज़रूरी है कि मेकिंग कनेक्शंस, एंड दैट इज़ थ्रू द कम्युनिकेशन, empathy and moreover एक personal touch. तो ये मेरे लिए सबसे ज़्यादा ज़रूरी है day to day life.
Thank you, Saurabh, for sharing that. And even personally for me, मैं भी जब लोगों से बात करता था, मेरे लिए सबसे ज़्यादा important वही था कि I want to make friends, ताकि वो मेरी help करे उस टाइम जब मेरे को सबसे ज़्यादा ज़रूरत हो. And I am so proud to say that I have seriously good friends जो मेरी पूरी college life में जिन्होंने बहुत ज़्यादा help करी है. Apart from that,
book पढ़ा था क्या?
कौन सी?
How to make a friends?
How to नहीं बट हाँ ये जो इंस्टीट्यूशंस वगैरह होते हैं वो आपको ज़बरदस्ती फेंक देते हैं उधर कि नहीं आप दोस्त बनाओ वरना आप यहाँ पे सस्टेन नहीं कर पाओगे. सो दैट हैज़ बीन क्वाइट हेल्पफुल. मूविंग ऑन टू अनदर टॉपिक दैट आई वांटेड टू टॉक अबाउट वाज रिलेशनशिप्स. जैसे मेरे लिए पर्सनली बहुत चीज़ें इस टाइप की रही हैं जहाँ पे आई हैव गॉन टू अ डेट एंड आई सी देयर मूड चेंज आफ्टर दे सी मी वॉकिंग विद अ लिम्प, राइट? तो आपके लिए लाइफ में रिलेशनशिप्स और उन सिनेरियो में कैसे रहा, especially for people who are married, how did you handle the things? आपके लिए क्या challenges वगैरह आए and how did you overcome it? More importantly than that.
इसमें मेरा expertise नहीं है.
So what had happened is that so most of the times क्या होता है ना मेरे साथ, मैं शुरू से यही मानता हूँ कि you have to be honest irrespective of whatever happens. Maybe yes, maybe no. Initially in colleges you have infatuations, and even when you are at a marriageable age, you feel कि यार शादी करनी है, अगर बता दिया हेमोफिलिया का तो क्या होगा क्या नहीं होगा. But I feel that बता के चलना चाहिए. If that person has to be with you, they will be with you. Of course you will face rejections, you have to accept it. कि if you tell to, let's say 10 people you tell to, 8 of them are going to say no to you for the reason that they feel that you are less normal than normal people. But if you don't tell, that will be as equal, it will be equal to cheating to the other person as. So it's always better to be honest and honest about it, that I have this condition and this is a part of my life, but not the entire, as I said earlier, it's just a part of me, not the entire me. That's it.
तो यहाँ पे ये जैसे बोल रहे हैं कि तो ये सिर्फ फ्रेंड्स के लिए नहीं होता है, मतलब फ्रेंड्स के नहीं होता है, फ्रेंड्स के लिए भी होता है, क्योंकि फ्रेंड्स भी ये होते हैं जो सपोर्ट करते हैं आपके कॉलेज लाइफ में. जैसे रंजन ने बोला कि बहुत ही हेल्पफुल थे, तो हमारे भी कॉलेज लाइफ में ये डिस्क्लोज करना बहुत ज़रूरी है, क्योंकि डिस्क्लोज करने से ही आपका जो होता है रिलेशनशिप और अच्छी तरह और स्ट्रेंथन होता है. तो जैसे भी शादी, यहाँ हमने देखा है हेमोफिलिक्स को बिना बताए शादी किए हुए, हमने देखा है लड़कियों को जो कैरियर है उनका बिना टेस्ट करके शादी किया गया, फिर उसका क्या प्रॉब्लम्स हुए हैं, उनको कैसे डिवोर्स तक पहुंच गया, फिर दूसरी बार जब शादी हुई फिर उनको बता के किया गया. तो ये सब जो कॉन्सिक्वेंस है, आप देखिए, आई विल से कि आई एम वेरी लकी कि मेरा जिसके साथ रिश्ता हुआ तो एक ही बार में उनको डिस्क्लोज भी किया, वो एग्री भी कर गई, फिर हमारी शादी भी हो गई. और इन दी मैरिज नाइट मैं फैक्टर इन्फ्यूज कर रहा था रात को बैठ के आफ्टर माई मैरिज इन फ्रंट ऑफ हर. तो ये वो डरी नहीं, ये डरी नहीं वो. दैट इज़ दी स्टोरी आई वांट टू टेल, बिकॉज आई हैव ए फ्रेंड कि वहाँ देखा मैंने, तो आफ्टर द मैरिज ही वॉज अ वेरी हेल्दी, मतलब इन द सेंस ही हैज़ हेमोफिलिया, वो उसको डिसेबिलिटी नहीं है, वो बहुत ही सुंदर है लड़का, ठीक है. बिना बताए शादी किया, शादी के फर्स्ट नाइट ही ब्लीड हुआ, फिर रात को उसको एक चीज़, उसका मतलब हेमोफिलिया है लेकिन वो कम फैक्टर लेता है, उसको नहीं लगता है, ज़्यादा नहीं लगता है. तो फिर वहाँ पे ये हालत हो गया कि रात को जब ब्लीडिंग हुआ कि उसको सेल्फ इन्फ्यूजन नहीं आती है, रात को 4 बजे मैं जाके उसको इन्फ्यूज कर रहा हूँ. सो इट इज़ अ वेरी एम्बैरेसिंग सिचुएशन फॉर हिम इन फ्रंट ऑफ हर वाइफ कि ये सिचुएशन जब आए, तो ये तो भगवान का कृपा है कि उसका शादी का कोई प्रॉब्लम नहीं हुआ. तो ऐसे बहुत सारी स्टोरीज़ हैं, जैसे कि मैं बोला कि कैरियर बिना बताए माता पिता ने किसी का टेस्ट किए, किसी लड़की का शादी कर दिया, फिर उसको डिस्क्लोज किया कि हमारा बेटी जब प्रेग्नेंट होगी फिर हम उसका टेस्ट करवाएंगे, फिर वहाँ पे शादी टूटी, फिर जब दोबारा उनका शादी किया गया फिर डिस्क्लोज करके किया गया। ये काफ़ी इम्पोर्टेंट होता है कि एक रिलेशन को बिल्ड करने के लिए, एक आपको कॉन्फिडेंस में लाने के लिए आपका पार्टनर को, वेदर इट इज़ ए गर्लफ्रेंड, वेदर इट इज़ ए वाइफ, हस्बैंड, स्पाउस, एनीवन, या फिर दोस्त भी हो, तो ये बोलना काफ़ी ज़रूरी होता है।
मैं एग्री करता हूँ सुभाषिश से, और ये डे टू डे लाइफ में हम लोग चूँकि की पर्सन्स हैं तो हमेशा चीज़ों को देखते ही आए हैं, और चाहे कैरियर की बात हो, चाहे हेमोफिली की बात हो, और जहाँ मैरिटल स्टेटस की बात करते हैं तो उसमें हम लोग वहाँ पे पंचायत भी करते हैं सोसाइटी में बैठा के। जैसे अब सुभाषिश ने बताया कि कैरियर की शादी हो गई, बच्चा पैदा आया तो उनके ससुराल वाले आए, इसी तरह से हेमोफिलिया में आया, अगर उन्होंने बताया नहीं, अगर डिसेबिलिटी को छिपा के शादी कर दिया, तो इस तरह की दिक्कतें आई है। लेकिन मुझे ऐसा लगता है कि इन सभी के पीछे डिपेंडेंसी और इंडिपेंडेंसी काम करती है। अगर हमारी कोई बच्ची कैरियर है तो उसको इंडिपेंडेंट बनाओ, हेमोफिलिक है तो उसको इंडिपेंडेंट बनाओ, क्योंकि पैसा एक ऐसी चीज़ है कि अगर उसके पास या स्किल, इतना बढ़िया स्किल हो कि पैसा आए, अगर पैसा एक एडिक्वेट अमाउंट में आ रहा है तो मुझे नहीं लगता कि इस तरह की बहुत बड़ी दिक्कतें आनी है, क्योंकि हमने अक्सर देखा है कि झगड़े वही हुए हैं जहाँ पे क्रंचेस रहे हैं पैसों के। मुझे ऐसा लगता है कि, और चूँकि हमारे यहाँ अक्सर इस तरह की चीज़ें आई हैं हमारी सोसाइटी में, जितने बच्चे हैं, एक तो वो बच्चा दिव्यांग हो गया, फिजिकल डिसेबिलिटी आ गई, कुछ कर भी नहीं रहा है, तो बीवी उसकी तो झगड़ा करेगी ना। अगर वो बच्चा अगर सेल्फ सस्टेन्ड हो और इफ़ इज़ हैविंग अ गुड बिजनेस, अर्निंग सम गुड मनी, तो वो सिचुएशंस में भी हैंडल, मुझे ऐसा लगता है। तो अभी वहीं पे ऐसे बहुत सारे फैमिलीज हैं जो अच्छा बिजनेस रन कर रहे हैं, उनकी बीवी बहुत खुश है, कोई दिक्कत नहीं, हाँ सर है, कोई दिक्कत नहीं, मुझे कोई प्रॉब्लम नहीं। और वहीं पे ऐसे लोग भी हैं, अरे इनको तो ऐसा है, अरे इनको वैसा है, चूँकि ही इज़ नॉट अर्निंग मनी। तो मुझे लगता है कि इन सब चीज़ों के पीछे कहीं ना कहीं पैसा बहुत बड़ा काम करता है, और इंडिपेंडेंसी अगर रहती है, चाहे कैरियर की चाहे हेमोफिली की, तो डिसेबिलिटी के बावजूद भी मुझे लगता है कहीं ना कहीं चीज़ें अच्छी चल जाती हैं।
थैंक यू सो मच संदीप। एक लास्ट क्वेश्चन मेरा रहेगा सबके लिए कि आपका फ्यूचर से एक्सपेक्टेशन क्या है? क्या आपको लगता है कि चीज़ें चेंज करनी चाहिए? एक दो लाइन में जस्ट जो आपको लगता है सबसे ज़्यादा इम्पोर्टेंट फोकस होना चाहिए, जो आप इस पूरी असेंबली को एड्रेस करना चाहते हैं।
तो यहाँ पे मैं एक चीज़ बोलूँगा कि इंडिपेंडेंस, ठीक है, दैट इज़ दी वर्ड, राइट वर्ड, फिनेंशियली इंडिपेंडेंस, इंडिपेंडेंस फ्रॉम डिसेबिलिटी। तो इसके लिए हमें बहुत सारे काम करने हैं, ठीक है। इंडिपेंडेंस फ्रॉम रिजेक्शन, ठीक है। तो ये सब इंडिपेंडेंस हमारे पास रहेगा तब जाके हम, तो इसके लिए आज HFI हमारा रोल और आज PWH हमारा खुद के ऊपर कुछ दायित्व है, उन सब के ऊपर हमें ध्यान देना चाहिए। जैसे कि HFI जैसे हो गया, जैसे आज के डेट में इतने फैक्टर नए थेरापीज़ आ गए हैं, आपको लग ही नहीं रहा होगा कि हेमोफिलिया, हम फ्यूचर की बात कर रहे हैं तो जीन थेरापी भी आ रही है, अभी के डेट में न्यू थेरापीज़ आ रहे हैं। तो यहाँ पे ब्लीडिंग एपिसोड बहुत ही कम हो गए हैं, और डिपेंडेंस मतलब डिसेबिलिटी के ऊपर भी बहुत कम होगा। जो हो गया उनका तो कुछ कर नहीं सकते आज के डेट में, लेकिन जो नहीं है उनके ऊपर हमें बहुत ही ज़्यादा फोकस करना है। हेमोफिलिया फ्री ऑफ पेन एंड विदाउट डिसेबिलिटी, यही विज़न है, इसके ऊपर हमें और ध्यान देना चाहिए और काम करना चाहिए।
So I just feel, मेरे को ये लगता है कि the only one thing which I would want the future of hemophilia should be कि as Subhashish rightly said, independent, and second, the perspective that you are not way different from any other. You are as normal as other children. You can play football, you can play cricket, you can do whatever you want to do. Do good in your studies and everything. So that is what I think the future should look like for hemophilics.
For me, as a youth chairman of HFI, I feel no youth in the country should feel left alone. उनके साथ कोई ना कोई हमेशा है, ऐसा मैं चाहूँगा कि लगे। एंड यूथ 18 to 30 year old जो भी हमारे हेमोफिलिक है, उनको अगर राइट गाइडेंस मिलता है सही टाइम पे तो दे कैन बी अ नेक्स्ट सौरभ, राइट? मेरे जैसा, मैं खुद को रोल मॉडल नहीं बनाना चाहता, लेकिन मैं बताना चाहता हूँ कि आप कुछ ऐसा कर सकते हो। तो मैं चाहता हूँ कि हमारे नेक्स्ट जो हमारे अभी 10 साल पूरे हुए हैं, हमारा जब 20th ऐसा प्रोग्राम हो, ऐसे 50 लोग हमारे पास हो जो कि एंटरप्रेन्योर है और लाइफ सबकी चेंज कर रहे हैं।
यहाँ पे अपूर्व जैसे बोला कि फुटबॉल खेलेंगे, ये खेलेंगे, तो यहाँ पे ये मैं बात बोल रहा हूँ कि हमारा एक है तिनसुकिया चैप्टर है इन आसाम, डिब्रूगढ़, तो वहाँ पे AMCH है, आसाम मेडिकल कॉलेज एंड हॉस्पिटल, वहाँ पे डॉक्टर अनुपम दत्त हैं, तो ही इज़ द ट्रीटिंग फिजिशियन ऑफ देयर। तो वहाँ पे आसाम में आपको तो पता होगा कि ट्रीटमेंट फैसिलिटीज़ बहुत अच्छे हैं। हम बचपन में सुनते आ रहे हैं कि कोई हेमोफीलिया का भी एवरेस्ट को सबमिट किया, तो ये हमारे लिए बहुत बड़ी बात है कि भाई कोई हेमोफीलिया एवरेस्ट को सबमिट कर दिया, मतलब चढ़ गया बच्चा। तो यहाँ पे एक चीज़ मैं बोलना चाहता हूँ, उन्होंने वहाँ का ट्रीटमेंट फैसिलिटी के बाद वो लोग एक बार बच्चों को लेके चले गए पिकनिक, तो वहाँ पे बच्चे फुटबॉल खेल रहे हैं क्योंकि सब एमिसिजुमम है, किसी को ब्लीड हो नहीं रही है, तो इतना ज़बरदस्त खिला, तो डॉक्टर बोल रहे हैं कि अगली बार आपको पिकनिक नहीं लेंगे। तो ये हमारा फ्यूचर होना चाहिए कि every hemophilic should have a normal life and a contributing person to the society. Thank you.
यहाँ पे अगर मैं अपनी बात रखूँ तो वही सेम चीज़ है इंडिपेंडेंसी वाली, और इंडिपेंडेंस और कॉन्फिडेंस दोनों एक सिक्के के दो पहलू हैं। अगर हमारे पास पैसा होगा तो हम कॉन्फिडेंट होंगे, तो अपने आप के अंदर इतने सारे स्किल्स को डेवलप करें कि पैसे आए और उससे हम सब कुछ, वो मुझे नहीं लगता कि उसमें कहीं भी किसी तरह की वो ट्रीटमेंट भी खरीद सकता है, उसके पास अच्छी पत्नी भी हो सकती है, उसके पास गर्लफ्रेंड हो सकती है, मतलब कहीं भी हर समस्या के पीछे अगर देखा जाए तो पैसा मोस्टली काम करता ही है। तो अगर हमारे पास पैसा है तो मुझे लगता है कि यूथ को कोई दिक्कत नहीं होनी है, किसी भी फील्ड में अपने आप को बहुत ही हाई रख सकता है।
थैंक यू सो मच। मैं भी सिर्फ एक ही चीज़ बोलना चाहूँगा कि आगे के फ्यूचर जनरेशन सारे हैप्पीनेस पे ज़्यादा फोकस करें, खुश रहें, राइट? एंड एक चीज़ और कि आप सब इनके लिए जैसे रोल मॉडल रहे हैं सब लोगों के लिए। इज इट नॉट वर्किंग? यू कैन हियर मी, राइट? सो मैं सिर्फ यही कहना चाहूँगा कि जैसे आप लोग रोल मॉडल रहे हैं इन सब के लिए, आई वुड प्रेफर कि कल को जब मेरे पास ये दोबारा मौका आए, अपॉर्चुनिटी आए, प्रेम सर मेरे को एक और अपॉर्चुनिटी दे कि मैं लोगों से इंटरव्यू वगैरह ले सकूँ, आई वॉन्ट hundreds of people here who can become the role model for the next 1000, and it keeps on growing exponentially. Thank you so much.
So thank you so much, such a inspiring and motivating session. And Saurabh, you have not organized mementos or gifts for this session. The reason can be that you are yourself are the gifts for the society, for Hemophilia Society. So I would request all the guests here to give a standing applause to this such a inspiring and motivating session. You are the gift for the society, you are the North Star. आप समाज के लिए ध्रुव तारा हैं, हम सब के लिए प्रेरणा का स्रोत हैं. Thank you so much for sharing your personal anecdotes. Just a minute. Thanks a lot for sharing your personal anecdotes and experience of your life, which is inspiring for all of us. So we have a lunch break now, and afterwards we will take up your query. Let's break for the lunch. Thank you.
सर मेरा बहुत छोटा सा सिंपल सा क्वेश्चन है। जो हमारा भारत का जो हेल्थ स्ट्रक्चर है जिसमें हेल्थ और हॉस्पिटल आता है, सो जब भी आप अगर बात करें, मैं छोटा सा इंट्रोडक्शन दूंगा कि हमारे सब सेंटर है, PHC है, CHC है। CHC ऐसा एक पड़ाव है जहाँ पर आपको स्पेशलिस्ट मिलता है, अदरवाइज नहीं मिलेगा नीचे में। फिर अपन ऊपर चलेंगे तो आपके SDH है, DH है, टर्शरी केयर है, सुपर स्पेशलिटी है, फिर क्वायर केयर। सो जब हम अगर पेशेंट पर्सपेक्टिव से सोचें तो जब आपको एक रेफरल के लिए आपको कभी कोई दिक्कत आई, रेफरल है, OPD है, सो जो प्रशासनिक व्यवस्थाएं आपको एक गवर्नमेंट हॉस्पिटल में चाहिए, तो अगर मैं आपसे पूछना चाहूँ कि आप जब जाते हैं तो आपको क्या दिक्कत आती है जिसको गवर्नमेंट अगर टेकअप करे, सो वो कौन से 3 या 4 पॉइंट है जिसको ध्यान में रखना चाहिए गवर्नमेंट?
सर मैं बताऊँ तो एक एग्जांपल देना चाहूँगा। ये जो ऑडिटोरियम है ये मुझे सबसे ज़्यादा पसंद आया, ठीक है। इसका मेन रीज़न ये है यहाँ आने की एक्सेसिबिलिटी सबसे अच्छी है, ठीक है। ये रैम्प है। तो मैं एक ऐसे सेंटर गया था, हीमोफिलिया ट्रीटमेंट सेंटर, जहाँ पे सेकंड फ्लोर पे वो यूनिट था जहाँ पे आपको चढ़ के जाना है और इट इज़ मल्टीपल टाइम्स यू हैव टू गो। पहले आप डॉक्टर के पास जाइए, लिखवा लीजिए, फिर केस पेपर निकालिए, फिर से ऊपर जाइए। सो दैट सिस्टम शुड बी रिफाइंड और इट स्टार्ट्स विद द एक्सेसिबिलिटी कि कैसे पेशेंट पहुंच रहा है। अगर ये हम डिफाइन कर पाए तो आगे की सारी चीज़ें सॉर्ट होता शुरू हो जाएंगी।
और एक रेफरल मेरे को ज़्यादा इंपॉर्टेंट लगता है, क्योंकि हमारे पास नीचे स्क्रीनिंग डायग्नोस्टिक तो हो जाएगा, बट आपको ट्रीटमेंट के लिए टर्शरी केयर जाना पड़ेगा। सो कभी आपने ऐसा फील किया है कि मेरा डायग्नोसिस तो हो गया बट मैं ट्रीटमेंट के लिए घूम रहा हूँ अभी भी, एज फार एज आर गवर्नमेंट हॉस्पिटल्स आर कंसर्न?
तो आई वुड लाइक टू आंसर दिस क्वेश्चन। मैं लाइफ में 3-4 डिफरेंट सिटीज़ में रहा हूँ एंड आई हैव ऑलमोस्ट टेकन केयर ऑफ द फैक्ट कि मैं खुद जाके वहाँ पे पता करूँ कि वहाँ पे ट्रीटमेंट कैसे कर रहा है। एंड द होल प्रोसेस, जब आपके स्पेशली ब्लीड हो रखा है, बहुत ज़्यादा डिफिकल्ट होता है। आपको इन्फॉर्मेशन नहीं होती कि कहाँ जाना है, किस फ्लोर पे जाना है, किससे बात करनी है। तो वो मेरे लिए सबसे बड़ी दिक्कत रही है। तो वो एक पॉइंट है जो एड्रेस कर सकते हैं। एंड सेकेंड थिंग इज़ कि एम्पैथी इज़ ऑल्सो समथिंग दैट आई हैव सीन गॉटन डाउन अ बिट in terms of the healthcare professionals, because they would treat, because they have to deal with so many people, burnout इतना ज़्यादा हो जाता है कि they are not able to handle these things. तो वो एक also एक important factor है कि how do you help health professionals become less burnout and treat more patients simultaneously, right? So that is something that needs to be handled.
तो यहाँ
So
पे
we
मैं
will-
एक सेकंड में बता देता हूँ। तो यहाँ पे एक ही चीज़ है कि हम आज हेमोफिलिया फेडरेशन ऑफ इंडिया और हमारे उड़ीसा के जो 4 चैप्टर्स हैं, तो हम मिलके यही काम करते हैं कि जितना नीचे से नीचे स्तर तक जाए और फैक्टर अवेलेबिलिटी हो, पीएचसी सीएचसी तक जाए। अभी तक तो डिस्ट्रिक्ट हेडक्वार्टर हॉस्पिटल में अवेलेबल है और हम बिल्कुल उड़ीसा में कोशिश कर रहे हैं और हमारे गवर्नमेंट ऑफिशियल्स और हमारे मिनिस्ट्री भी बहुत हमें इसमें सहयोग कर रही है कि हम पूरा नीचे तक जाके कहाँ पे वो अपने घर के पास कैसे फैक्टर दे सके, इसके ऊपर बिल्कुल कोशिश चल रही है और हम आगे चल के उम्मीद रखते हैं कि ये अवेलेबल रहेगा। थैंक यू।
आप भी होम केयर की एडवोकेसी कर रहे हैं, आई थिंक सो। होम केयर अभी जो आप यहाँ पर दे रहे हैं, ठीक, होम थेरेपी।
Sir, we will continue this discussion offline while breaking the bread.
Thank you so much for
Thank
giving
you.
me this opportunity, sir.
Thank you. Thank you so much. Thank you so much.
साले ऐसे जड़प से बना था।